Well, the first timeline is the university. Right. And so you're keeping all the other crops. So you have to get into you want to be south in that early. Well, it's not dealing too well. So
you can just start. Okay.
Good morning, everyone. Welcome to our older adults conference. It's really great to see everybody, and I know that the room looks a little bit empty. We're having, as you, some of you know, we're having issues with our parking ramps. I thought once you get a voucher, your life changes, and it's so easy. But I guess the voucher isn't the magic golden ticket that I was led to believe it was. But welcome. I'm Nancy Frank Wilson with the Minnesota Oral Health Coalition, and we are co-hosting with our friends at the Minnesota Department of Health. Just a little bit of housekeeping. Make sure that you did grab a parking voucher. It does work for other ramps in this area. So if you didn't get to this ramp, you can still use it. If you end up paying for parking, just let me know. We don't want you to pay for parking. Restrooms are just past the registration table. So if you just go out and go past there and you'll see the restrooms. Let's see. They told us to use the Wi-Fi graduate meeting instead of graduate guest. I guess if you're graduate guest, they kick you out. Let's see. So just one other thing about today. Today we intended to be casual. We have an important issue and we have a lot of things to share. But if you need to go to the bathroom, you need to go do something, go do it, come back. If you have a question, raise your hand. We're here together to learn and to connect with each other. So please enjoy your time with us today. I know that we will. So thank you.
Thank you. That's why we have the tech guy in the room.
Yes.
It's not getting me to change the.
yeah. This is
Good morning, everyone, and welcome to the HRSA Grantee showcase. And we intended to keep this showcase to be small because we need to talk about important issues. So we didn't make it open to the public. So that's why you will not see a lot of folks like you see in our traditional conferences. So as the state oral director and also the principal investigator of this HRSA grant, I'm deeply honored and humbled to welcome our HRSA partners, aging leaders, fellow grantees, collaborators, and all our friends today. Today is more than a showcase. I get so emotional talking about the fact that it is a celebration of 4 years of tireless work, unwavering commitment, and meaningful collaboration with each one of you. Together, we have reimagined how we prepare and support the Orland workforce, strengthen partnership across sectors, and advance innovative, age-friendly models of care that are making a real difference in our communities today, especially in dental professional shortage areas. This progress belongs to each one of you. Your dedication, resilience, and passion have transformed ideas into action and challenges into opportunities, which we were very ambitious about when we were actually writing the grant. And I still remember reaching out to Dr. Shuman because I had done the mini residency with him. And I told him, like, we have this HRSA funding opportunity. And Dr. Shuman was like, Prasida, do you know about age-friendly health system? And I'm like, okay, what is that, Dr. Shuman? So he sent me resources to read. And here we are today, 4 years down the lane, we have so many scalable models. And I'm very excited that today we will share those innovative projects and impact that our partners are making. So this would not be possible without our statewide partners, because as Minnesota Department of Health or that program and our statewide coalition, we can only do so much in terms of bringing in funding, but it's really the partnership that has done wonders. And I'm looking forward to a productive day. And as Nancy mentioned, please feel free to interrupt us anytime. Let's make it like a learning experience. And I hope you have a wonderful day. Thank you.
Thanks, Prasida. I'm so happy to have one of our really important partners here today to say hello. Please help me welcome the president-elect of the Minnesota Dental Association, Dr. John Noack.
Morning, everybody. As mentioned, I'm John Noack. Can you hear me all right? I'm president-elect of the Minnesota Dental Association. And on behalf of the MDA, I would just like to thank the Minnesota Oral Health Coalition for putting this together tonight, and also just to extend greetings from our organization. So we appreciate being here. The topic of this event, I was telling Nancy, this is kind of near and dear to our heart, my heart too. Personally, you know, my dad's in a nursing home. I've just seen his oral health just decrease. And it's an issue even in nursing homes. So Nancy kind of shared her dad's story too, but these topics, they don't get nothing gets accomplished just on their own, and you need cooperation and collaboration. So I appreciate being here, being asked to be here for that part. The MDA is grateful to be part of that work. And I just want to share a couple of examples of what that partnership looks like in practice. Over the past several years, the MDA has collaborated with the Minnesota Oral Health Coalition to put on the Oral Health Care Showcase at the state capitol. This is where we bring together dental stakeholders and to the Capitol Rotunda, and where legislative officers are invited to stop by, hear what we have to say, and learn firsthand about what our profession does and the patients that we serve. It's a simple idea, but a very important one. When policymakers can see and just touch and feel where the policymakers or what we do as professionals, more stuff gets done. So the more we're out there and collaborating together, it's really a good way to do it. And it just becomes a more important part of the oral health care policy in our state. It's one of the many examples of why the MDA is always eager to team up with somebody and collaborate together with a lot of the individuals here in this building. That same spirit of collaboration is especially relevant in today's focus on older adults. The MDA has been proud to support the development of the dementia-friendly dental practice initiative and its accompanying training resources. We're one of the few states that actually has something like this going. This work was made possible through collaboration with the University of Minnesota's Northstar Geriatric Workforce Enhancement Program, the Delta Dental of Minnesota Foundation, the University of Minnesota School of Dentistry, and Act on Alzheimer's. I especially want to recognize Dr. Steve Shuman, who's worked at the U now for a couple years, few years. He's also chair of the MDA's Barriers to Care Committee, and whose leadership was instrumental and impactful in bringing this initiative to life. Dental professionals play a vital role in the lives of people with dementia and their families, and this training helps ensure that those members are prepared to provide care with understanding and compassion that these patients deserve. As we look at the road ahead, I'd be remiss not to mention a current challenge that touches every initiative contemplated or underway: the dental hygiene and dental assistant shortage facing our state currently. This is an issue that the MDA continues to focus on intently, because the shrinking workforce doesn't just affect access to the abstract, but it also directly impacts our collective ability to bring oral health care to people that need it the most. And that absolutely includes older adults here in Minnesota who are counting on us. Addressing this crisis will require the same type of collaboration that you see represented in this room today. Thank you for the work you do. Thanks for being here, and I look forward to today's presentation, and most importantly, truly to work together. So thank you.
Thanks so much, Dr. Noack. We have had some really great collaborations. I love the Oral Health Showcase. We also did a really great dental assisting recruitment program, and we've included it in the Spanish language now, and we still get a lot of use out of that in those materials. So thank you. Next, I'm really proud to introduce Mohammed Selim. He is the Minnesota Oral Health Coalition board chairperson, and he is with mHealth Fairview. And so welcome. Thank you for being here.
Well, good morning and welcome, everyone. My name is Mohammed Selim, and I have the privilege of serving as the board chair for the Minnesota Oral Health Coalition since 2021. First, I want to say thank you to the Minnesota Department of Health and to Dr. Prasida Khanal, our state oral health director. Thank you for your partnership. I would also like to thank Nancy for all the work putting this conference together and everything else you do for the coalition and oral health in the state of Minnesota. The Minnesota Oral Health Coalition and MDH have been linked since our founding in 2009, and that relationship is built and grounded in a shared belief that oral health is public health. The coalition's mission is simple to say, yet hard to do. So our mission is to strengthen Minnesota's oral health community through partnerships, resources, and outreach. Our vision is to have optimal health for all Minnesotans. So I want to sit on the word all for a second, and today it has a very specific meaning. Minnesota's older adult population is growing faster than any other age group we serve. So if our vision is going to hold, our system must grow with it. Today is a small part of how we grow the system. So convening partners like you, building workforce pathways, as Nancy just mentioned, so providers are trained in geriatric care before the need arrives. We also should be amplifying rural and underserved voices because access looks very different across our state, and translating data into strategies that actually change practice and policy. So later, I know you'll hear from some of the grantees that are doing exactly that. So I encourage you to listen to what you can borrow from others, and perhaps find someone at lunch that you haven't met yet. And with that, I just want to thank you again for being here, and great to see all of you. Thank you.
Thank you so much, and thanks for always being such a great support. And if anyone knows me, I do talk a little bit, and Mohammed is a great listener. So that's another big one. So thank you and welcome. And I'm really proud to introduce back to the podium my friend and colleague, Dr. Prasida Khanal.
Thank you, Nancy. Maybe we need the tech person too. think we need him again. Just switching. Yeah, I think it's working, right? So. Good morning again. Are you able to hear me okay? Okay.
Yeah.
I'm going to keep it very basic because I'll leave Dr. Shuman and others do a lot of talking later. So I'm basically going to talk about Golden Smiles, advancing age-friendly dental public health system in Minnesota. We need the tech person, I believe. Okay. So the goals of my presentation is to describe Minnesota's aging landscape and oral health disparities among older adults, if you're not familiar with it yet. Describe Minnesota's age-friendly dental public health system to advance health equity among older adults. Discuss HRSA grant activities integrating age-friendly health system frameworks in Minnesota. So basically, I'm going to provide an overarching overview of our HRSA grant and introduce our official partners and projects. So as Dr. Mohammed Selim was talking about, Minnesota's population getting older, older adults represent a rapidly growing demographic in Minnesota. More than 1 in 5 residents in all Minnesota counties will be age 65 and older by 2030. They likely will be an increasingly large part of dental practice in coming years, but it also has an impact on housing, economies, and a lot of work that our public health professionals or community health workers are also doing. So with the graying of the state, according to the research published in 2025, 93% of adults aged 65 and older have at least one condition or comorbidity, while 79% of them have 2 or more conditions. So as we are happy that older adults in Minnesota continuing to give back, they're volunteering, they're voting, they're really still working, and they are living longer. And they are also retaining their teeth, but they are also living with more and more chronic conditions, which has really an impact on oral health as well as their overall systemic health. So there are many common oral health problems faced by older adults. Although better than in the past years, the typical aging patient's baseline health state can be complicated by comorbid conditions, as I was talking earlier, be it hypertension, diabetes, or physiological changes associated with aging. Older adults may regularly use several prescription and over-the-counter medication, as many of you are already familiar, making them more vulnerable to medication errors, drug interactions, or adverse drug reactions, and many of you might have heard about dry mouth. Potential physical, sensory, and cognitive impairments associated with aging may make home oral health care, and patient education communications challenging. And that's where we have many projects where our community health workers and educators come in. Dental conditions associated with aging include dry mouth, different kinds of root caries, and also periodontitis, which is a very advanced form of gum disease. And patients may show increased sensitivity to drugs used in dentistry, including local anesthetics and analgesics. So this showcase is really trying to put the mouth back in the body. And that's why we need to come together as medical and, like dental as well as public health professionals. So the oral systemic linkages is not a really new thing, but I know especially at Department of Health, 8 or 9 years back when I took the position, oral health was still, it was not part of the general health. But now I think our executive office, my supervisors, and a lot of our leadership has been hearing about oral health, not just from oral health partners, but from our public health professionals, from care navigators, from a lot of task force. So there is an increased awareness about oral systemic linkages, which is like the bidirectional referral, right? And then disease, including but not limited to cardiovascular disease, Alzheimer's disease, dementia, obesity, metabolic disorders, rheumatoid arthritis, and several cancers have been associated with oral health as well as general health. So long story short, oral health is an integral component of health and well-being. And I am the testimony that there has been that heightened awareness among our leadership, which is really nice, right? Because we do get policymakers talk about oral health as well, because they do have lived experience of not having dental access themselves. So it's really nice to see the increase in awareness, both at the population level, at the partners level, as well as those leadership level, where a lot of policy decisions are being made. And no matter like how much we talk about all these improvements, I think I do see the needle moving, but it's that older adults in Minnesota face barriers to dental access in terms of seeking care, reaching care, receiving care. So many times I've received calls from adults literally crying over the phone. And they are like, you guys are oral health program. Why don't you help my dad in the long-term care facility? So-and-so dental clinic was supposed to come and take care of him. He's dying. I know he does not even have a few more days, but he's not able to eat and he's crying. And other than connecting him to the hotline, the crisis line, there wasn't much I could do. So it just, that was the time when I was feeling like very helpless and vulnerable and sitting there and thinking, what are we doing as oral health program? Because we are also very limited in our capacity and funding. And that's when the HRSA opportunity came out. And I reached out to Dr. Shuman because I want to remember Mary Manning and Don Bishop, our division, my former supervisor and division director, who are aging themselves and were at the point of retirement. And they were the ones who said, Prasida, you have to focus on older adults and aging. And I was like, okay, where do I start? So I went to Dr. Shuman's mini residency, and that's where I started. And we were talking, and he was already talking about, medical dental integration, nursing home facility codes. And I was like, I'm just starting with older adults. Let me, process everything. So this is a map that shows dental professional shortage areas in Minnesota. And I'm sure all of you are familiar that over 50% of our counties are designated as dental professional shortage area. And I think in a bit, we'll have a presentation from MDH, Office of Rural Health and Primary Care, and they'll be talking about workforce survey. So it's so interesting that we do have enough dentists to serve our population, but it's not really the shortage, but the inequitable distribution of our workforce that is creating this shortage. And I think there is not as much awareness about our dental therapists or dental hygienists who could at least bring patients or community members into the system. I'd like to talk about bringing community members into the system through our community health workers and hygienists, because they don't have to be patients, right? They are communities, healthy communities, right? If we focus on prevention, there's no disease or cavities. So that's really important. So this map here is really interesting because one of my colleagues, Jim Peacock from cardiovascular program, helped us create this map. So what we did was there's something called like naturally occurring retirement communities, because in our dental public health, whenever we are looking into the mouth of older adults through our basic screening survey, our research methodology takes us to nursing homes. So there is a framework, there is a set, demographic, right? But then there are so many older adults aging in place. There are so many communities where, older adults are really with their families, being taken care of. So we do not screen them at all. So they are literally outside of our, scope or our research or data. So if the priority population is not represented in our data, then the policy we make may not be inclusive of all those who actually are vulnerable and need these policies to impact their lives. So what he did was he took the naturally occurring retirement communities. These are communities that is created using census tract data. So in Minnesota, if there are 60% or more household owners in that particular area that are older adults, we call it North. That's the definition we use for this map. So you see that most of the green shaded areas, especially the dark green areas, those are naturally occurring retirement communities. So the first time we know outside the nursing home facilities where our older adults are living, and most of them are living in these dental professional shortage areas. And over 50% of these counties are already dental professional shortage areas. So that's where we felt that there was an opportunity to mobilize our community health workers to at least bring those older adults into the pipeline and connect them to a dental home. The other big thing is more than 65 million people nationwide count on Medicare for their healthcare, including senior citizens, once they turn 65, and many adults with disabilities. However, this health program does not include comprehensive dental care, a gap that pushes oral health care out of reach. So imagine I retire and then I have to use my out-of-pocket money to be able to even see a dentist, right? And then on top of that, if I have comorbidities, and I have disabilities, and there is like issues with even patient transfer, that is really making me vulnerable just because now I'm an older adult. This gap is especially harmful for seniors who live on limited incomes in rural communities because it's like really superimposing the issues that they were already facing, right? Or who face systemic racial inequities, because we do need to talk about those racial inequities that we see so commonly in our communities. So simply put, it worsens their overall health and well-being. So I'm just trying to emphasize how important our structural racism and, like the income, the policies, the bigger, like discussion around Medicare coverage is when we talk about older adults' oral health outcomes. So this was the open mouth assessment or basic screening survey that Minnesota Department of Health conducted in 2015. It was supported by Delta Dental of Minnesota Foundation. So we found that 42% of older adults have a dental care need. 2 in 5 older adults with at least one natural tooth have untreated tooth decay. And 3 in 10 older adults with fewer than 20 teeth, though that's the standard, we need to call it like functional dentition. They do not own dentures, but they need them. And the bias with our own survey is that 99% of our participants were Caucasian. So it does not include the kind of the beautiful diversity we see in Minnesota. So that is the reason why we have to think outside the box or imagine that there's no box in the first place. Because now you have to really go to those communities where our older adults are aging in place, right? So, but this, and we are still looking for funding to continue these kind of statewide surveillance. So against this backdrop, I think MDH oral health program reached to a point where I personally felt very vulnerable that, you are sitting here, you have the program, you can make a lot of policy changes, but what can you do about it? So that was the time when we felt like through the HRSA proposal, we could explore a broad framework for oral health system reform using innovative workforce models to address the national priority of developing healthcare workforce that maximizes patient and family engagement. Because dentistry is not just about fixing cavities or taking care of the disease, right? You have to also involve a lot of families because there is like informed consent. Some of the older adults have cognitive impairment, so you do want to involve them. And something that could help us combine geriatrics, oral health, and primary care, specifically in rural dental health professional shortage areas. So we felt that HRSA proposal, I would think, was very, very ambitious, but we still wanted to, try. So as I mentioned earlier, Dr. Shuman introduced me to the Age-Friendly Health System, which is the initiative of the John A. Hartwood Foundation and the Institute for Healthcare Improvement in partnership with American Hospital Association, which is designed to meet all the challenges I talked about head on. So the Age-Friendly Health System aimed to follow an essential set of evidence-based practice, cause no harm, and align with what matters to older adults and their family caregivers. And there are 4 M's: what matters, medication, mentation, and mobility. And Dr. Shuman will talk more about that in a bit. But the idea really here is to not really look at patient and just fix the dental problems, but see patient as a whole, right? Because so we did some surveys and focus groups with long-term care facilities, and we were trying to understand what matters to the residents in these facilities. So one of the elderly women, like one of the caregivers, shared that for this particular woman, getting her nails done, getting her hair done every week was what mattered. And it was on her chart. And now I'm talking about, you have to brush your teeth, you have to floss. No. Getting the hair done, the nails done are absolutely important, right? So what I'm trying to say here is that even as providers, sometimes things may not align because the priorities are so different, right? And there was another story where someone had anxiety and obsessive compulsive disorder, and that person was brushing that they had to literally take the toothbrush out of the room. So there are like so many stories that we hear where our older adults have dry mouth because they have multiple medication and they're asking for soda, and then there's like, unintended cavities, kind of. So we hear these stories, and it's really heartwarming. But in the meantime, there's so much to do in these spaces. And I still remember Nicole is not here today. Nicole is a collaborative practice dental hygienist with Apple Tree Dental, and she's spearheaded our long-term care facility project. And the first time she went there, she came back, and I still remember we were in Duluth for Rural Health Association, Rural Health Conference, and she's like, Prasida, do you know they are tracking hair brushing, but nobody is tracking toothbrushing. I was like, okay, we need to write this trend. This is so real. And we started not knowing how things even start in these facilities, right? So we do have come a very long way in these 4 years. So with that, I'd like to acknowledge our partners, University of Minnesota School of Dentistry, Dr. Susan McCurran and Dr. Shuman. You guys have been our mentors, and both of you are heading our mini residencies, fellowship, and they'll be talking more about how they are developing competent workforce. Apple Tree Dental, big shout out to your leadership in terms of, like all the nursing home partners you have. And thank you for helping us do the long-term care facility project and the dentistry. Volunteers of America, Tuesday, and Monisha Washington for helping us learn about community health workers. And they don't even have oral health in the curriculum. So introducing geriatric oral health, teaching them referrals, integrated intake form. It's been a lot of work over there. So thank you for helping us go to high rises. Last but not the least, health partners. We brought them along the way, and they helped us do medical, dental, electronic health record integration, and I'll be presenting on their behalf this afternoon. This grant established the foundation for long-term success by enabling MDH and its partners to develop scalable workforce models. Because as MDH, we believe in triple aim of health equity. We don't do dental public health at our desk. We really, mobilize our partners to implement health in all policies. We go out in the communities to understand what oral health means to them versus what is in the literature for us. And we also strengthen the capacity of communities to create their own healthy future versus us telling them, oh, we know what to do. You guys need to do that. It's really our partners who help us, drive our work. Definitely around evidence-based strategies, but we adapt it to the local needs. So that is the reason why our partners have really helped us build a sustainable workforce pathway for Minnesota. So these investments will support continued workforce development and improve health outcomes for older adults beyond the grant period through ongoing collaboration, integration with existing systems, whether it's medical or health professionals or public health systems. And also, our partners are looking for additional funding opportunities. The good news is that all our partners and additional partners have helped us put together a new HRSA funding cycle proposal already. So hopefully we get the grant and we continue the good work. So with that, I can stay back with you guys in lunchtime and answer more questions and share stories. But with that, Nancy, I'll hand it over to you. Can we take questions? Are there any questions for me at this time or about the HRSA grant? If not, it's Dr. Shuman's, right?
No, Dr. Fritsma. Dr. Fritsma.
So that's the dental HIPSs, yes.
Wait, no, do we know how to?
Yeah,
get-
so we
okay.
call her and then she.
Okay, good. I'm like, do we know how to get to the right, right slide? Yes.
Did you employ any, or did you use interpreters?
Yes, so we,
Can you repeat the question?
yeah, so the question is, I talked about how it's important to step out and look at older adults aging in place and talk about that diversity. So Dr. Crispo is asking like our strategies, how did we do that? So we didn't do it ourselves, we did it through our Volunteers of America. So we trained their community health workers and they are doing outreach in the communities, and they've done wonderful caregivers breakfast, and they already have access to high rises, right, Tuesday, and Tuesday we'll be talking more about that this afternoon. So we really mobilize our community health workers. We don't do anything without our community health workers in Orvik. So Tuesday you'll be talking more about that. Do you want to add anything right now, or yeah?
move forward. You hear more about it.
Yes, and thank you for helping us do that. Did you have a follow-up? Did you have a follow-up question, Dr. Chris?
I was just curious if you're only putting high rises. Are we looking?
Yes, they're doing outreach. So we, again, like it's really about trying to put the mouth back in the body. So we really are refraining from doing things that are, you know, like in our excellent silos of excellence. So what we are doing is even the intake form for those 4M questions, we created an integrated form with dementia screening and other things. So community health workers, when they're out and about, they don't have to have grants or be intentional about oral health. It's all integrated. So they already have their set outreach to different community events. And I think last week, Monisha was at the YMCA to do the work. So she wouldn't be there just for oral health. She would be there for dementia. She would be there for chronic disease. So again, like trying to put the mouth back in the body is helping us save resources and also maximize our reach. So that, I think that's a new approach that is helping us. And Tuesday, you and Monisha will talk more about that in the afternoon. Yeah. Any other questions? Yes.
What outcomes do you measure to see what the HRSA grant has done? Like, how long is the grant?
So the grant, we have it for 4 years, so it's ending August 30th, and we've already applied for the new funding cycle. So we have an evaluation plan, and our evaluator would be here this afternoon, and we'll talk a little bit more about that towards the end. But I think there are process evaluation and outcome evaluation that we do, because this is a new grant, so sometimes it's very hard for MDH to look at biomarkers or go at the individual levels. So we like to see things at the population and policy and system level integration. So we have questions where first we need to learn about the needs. So the grant allows us to do need assessment in year one, understand what the unique needs and solutions are for each target counties that we are looking at, especially in dental professional shortage area. So we basically are trying to evaluate the challenges that we encountered and what we did to overcome those challenges. But the broader evaluation question is, what kind of partnerships we build to make our grant sustainable beyond the funding cycle. And you would see wonderful outcomes of our work when our grantees are presenting and how they have taken some of these scalable models into the dental school curriculum, the tracks, or Volunteers of America trying to do it with the community health worker as an annual training. So there is a lot of system level changes that we've seen. I wouldn't say we are statewide and the work is done. This is just the beginning. At least we have scalable model that if there's more funding and resources, and again, trying to put that mouth back in the body through policy, we are ready. We just need more support at the state level to be able to sustain that work. But our partners have at least observed that work into their institution, which is already a very big, it's a remarkable, outcome for our work. But we do have a logic model and we have very specific nitty-gritty evaluation findings. We can share the report with you as well. And we'll see the impact throughout the day. So hopefully we'll have more numbers and stories by the end of the day. Are there more questions? And I see Kua. I just want to give a shout out to Kua because he recently moved to a new role as a planner principal, but he was my partner in crime. So Kua did all the work in 4 years, and it's just like hiding right now, but he's the star of the day. So Kua, big shout out to you. Like Nancy was saying here, he's so calm and like we really got along and got a lot of projects done. So just a big shout out to Kua as well. On her side. Yeah, I can do that.
Okay, great. Prasida will now be known as the slide whisperer. Okay, good. We always need someone like that. Thank you so much. And yeah, thank you. Good job. Thank you so much. Okay. Our next presenter is the lead healthcare workforce analyst at the Office of Rural Health and Primary Care at the Minnesota Department of Health. And that is really good data that we use a lot. So thank you. Please help me in welcoming Dr. Teri Fritsma.
Good morning. I feel a little funny carrying my Diet Coke in an oral health conference, but bear with me. My name is Teri Fritsma. I am the lead healthcare workforce analyst at the Minnesota Department of Health. Someone like me does exist. Actually, I'm just doing half of this presentation, and then my colleague Laura Sutter is gonna hop up to talk about HRSAs and talk about the Rural Health Transformation Program, which has taken over our office. So hopefully I can figure out how to move these slides. Yeah. Any suggestions for how to move the slides, guys? Yes. Oh. Okay. So I'm actually my slides are a little bit out of order. So for today, as I kind of hinted already, I'm going to talk a lot about the some data that we collect on the oral health workforce. Lately, when it comes to the healthcare workforce, including the oral health workforce, I'm kind of used to bearing a lot of bad news. And so I'm hoping that I can be the bad cop, and then my colleague Laura will come in and be sort of the good cop for this presentation and talk more about kind of some of the solutions to some of the problems that I'm gonna share with you. So with that, I will talk about the oral health workforce. I'm going to go back a little bit. So I just want to say a little bit about what my group does. We're just a small group. So for those of you who are licensed oral health professionals, you will be aware of the work that we do, because as you're going through and renewing your license, you'll be hit with our survey, and you have to take our survey in order to continue on and renew your license. And so we are actually statutorily mandated to conduct that survey. And as you will have seen, it's part of the license renewal process. And so we get close to 100% response rates on our surveys, which means that it's really, really high quality data. And we're in Minnesota, we're really proud of the data that we have. And just people, especially, I like to, when if ever I'm in front of licensees themselves, I kind of like to talk about where the data goes, and it goes all over the place. So for presentations like this, to help inform work groups that are studying and that are working on these issues related to workforce. We also do a lot of work with post-secondary institutions to help them do program planning. We do a lot of legislative requests for policy planning, things along those lines. Where roughly 50% of my time goes into just kind of doing special requests for people for data, which leads me to say, if you have data needs on the oral health workforce, I want to really invite you to get in touch with me or others on my team. It's what we do. And if you see something here, which I imagine that you will, that you're like, I'd like to dig into that further and see what's causing that or what's going on, I would really invite you to get in touch with us. My contact information is at the end. Also, by way of introduction, I'll just mention the data that I'm presenting today is the tip of the iceberg of what we present. We actually have a complete and relatively recent oral health report that's, I think it's close to like 75 pages. Prasida would know. And so, which has just tons and tons of current data on the oral health workforce. So I just wanted to mention that this may open up more questions than answers. So just to start off, this is what the oral health workforce looks like in Minnesota. This is the number of active licensees by our 4 different professions. You can see the majority of them are dental assistants. We have really, really a small number of dental therapists even still, just under 4,000 dentists. And to maybe put that in some perspective, comparing it to other professions, there are up close to 40,000 physicians licensed in Minnesota right now, close to 135,000 registered nurses. So the oral health workforce is very small, relatively speaking. And this shows you something I imagine you sort of feel in your day-to-day work, but maybe haven't seen the numbers. This is just the growth rates or perhaps lack thereof of all 4 oral health professions over the last 15 years. And I'm just looking to see if I'm forgetting anything. Yeah, you might be thinking that's they're not really growing, and you would be correct. They're really pretty stagnant. I think I read this is not our data, but I think I read that we are losing to retirement somewhere in the neighborhood of 160 dentists per year, and we're only graduating in Minnesota something like 120. So we're managing to hold steady, probably from importing some folks that are being educated in other states, but the workforce really hasn't grown much in the last 15 years. And this is just to kind of give you a sense of how dentists how our oral health professions compare to others in terms of growth rates. So even during COVID, we saw really huge growth rates for a lot of our advanced practice providers, like physician assistants, advanced practice registered nurses, even alcohol and drug counselors. And believe me, COVID has been a rotten time for all of these providers. But you can see that, so for dental hygienists, assistants, and dentists, the growth rate has been quite stagnant. Psychologists and licensed practical nurses are the only 2 that are actually shrinking, but dentists and assistants and hygienists are coming pretty close. So this is, and Prasida and others have already kind of hinted at this. This is just looking at where folks are employed around the state. And the point of this slide is just to kind of show you that dentists in particular, and also hygienists and assistants are quite, we call it, we have kind of a jargony word, maldistributed around the state, meaning that the bulk of dentists and a disproportionate share of dentists are working in urban areas. And so just to kind of summarize this slide, 15% of Minnesota's population are in small town and rural areas, and just 9.3% of dentists are working in those areas. And you might be wondering, is this better or worse than other professions? It's actually right in line with other professions. In fact, so like, for example, physicians, only about 4% of physicians are working in rural areas. So dentists are actually doing a little bit better than others, and worse than others. One kind of ray of hope that I want to point out here is dental therapists. So some of the push for licensing dental therapists is to try to fill some of those gaps in care in rural areas. And though there are very few dental therapists, only about 150 right now, according to our license counts, they are in fact slightly sort of overemployed. I don't want to use that word because it sounds like we should pull them back into urban areas, but they are actually representative of of the rural population. So that's a bit of good news. This is a super busy slide, but it's just, I think, to make the case that all of you here probably already understand, which is that rural areas are just in general much older than urban areas. And so, for example, just to kind of summarize some of these, a lot of these bars, about 44% of rural residents are age 50 plus, compared to about a third of urban residents. So one thing I wanted to mention is just, I sort of get curious about so far I've talked a lot about just kind of the supply of our workers and if it's sufficient or not. Something that I was curious about is the demand. So I looked up our job vacancy rates for dentists, dental assistants, and dental hygienists. There is no such rate for dental therapists yet because the federal government has not yet started to measure that. But the vacancy rates, so for the entire economy, the vacancy rate, which means the share of essentially current open for hire jobs, is about 4.3%. For dentists, it's about 5.5%. For dental hygienists, it's 10.5%. And for assistants, it's 8.4%. So higher than average. Not as high as I might have expected. And I think that has a little bit to do with community need, not always translating into hiring demand. Those are two different things. Okay. So this is just another way to look at the data, looking at where dentists are employed around the state. I always tend to look at the gaps more than the dots. The dots represent not just necessarily one person, but one location where dentists are working. And so you can see, not too surprising, a lot of areas on the state where you would have to drive quite a ways to access dental care or oral health care. Now, a little bit more bad news is in those small town and isolated rural communities, 1 out of 4, about 25% of dentists are age 60 or over. And that's represented by those kind of, I covered up the pink dots by the purple, or excuse me, by the red triangles. And so we can sort of see this, you know, a bit of a, as they say, a silver tsunami of those dentists within rural areas. So it's concerning. And then this is overlaying dental therapists and where they're working. And so you can see dental therapists can fill some of that gap, and that's really good, but there's only 150 or roughly 150 practicing in the state. So that's not gonna fill all the gaps of those retiring dentists. This is just a graph showing the share of providers who tell us that they plan to leave their profession within the next 5 years. Pharmacy technicians, there's a lot of turnover among pharm techs, so that's to be expected. Psychologists is a very aging profession, that's to be expected. And next is dentists. So we're looking at losing almost 1/4 or 1 in 4 of our licensed dentists in the next 5 years. So I'm used to providing bad news. And then again, kind of zeroing in on how this varies by region. So what we can see here, again, this is a little bit of a busy chart, but what you can essentially see is that we can anticipate losing about half, so about 50% of our dentists in isolated rural areas, that yellow bar, in the next 10 years. So we have to be thinking about how to replace those folks. One last chart, kind of unrelated to everything else that I've talked about, is just the share of dentists that have their own private practice, and also by region. And I think, not surprisingly, a really large majority of dentists have their own, they either own or they co-own a private practice in those rural areas. And I know I hear, and I imagine you do, a lot of talk about what happens when those dentists retire and their private practice just essentially goes away. Is there anybody to come and, you know, and fill their shoes in those rural areas? So I would refer you to our report for more information, and then I'll invite my colleague Laura to come up and talk about HRSAs and more rural health.
Hi all, good to see you. I know I've worked with some of you before. I am Laura Sutter. I am a supervisor in the Office of Rural Health and Primary Care at the Minnesota Department of Health. I have a long history of breaking clickers. Let's see if this works. Good, okay. So one of the teams that is in my unit is the team that manages the primary care office activities funded by HRSA, and that includes the state's health workforce shortage designations, health professional shortage designations, so HRSAs. And I'm going to give a brief overview of what these are and kind of our role in it, and then answer any questions you have. I may turf a bit. Some of you have probably worked with our HRSA wizard, Anna Odens. She's amazing. She is also on vacation. So I'm going to do my best to embody her today. And then, you know, we can always reach out to her afterwards if there's specific questions. So HRSA designations refer to an area with a shortage of health professionals. And it's authorized by Section 332 of the Public Health Service Act, and it's administered through federal regulations under that statute. So one thing to note about these shortage designations is that they're kind of a joint project. They're administered by HRSA, the federal agency, and then the state plays a role in managing each state's designations. The way they are calculated, it's kind of a four-part formula. There's a population to provider ratio that goes into it, percent of the population below 100% of the federal poverty line, water fluoridation status, and travel time to the nearest source of care. Those are the four components that go into the formula that result in your HRSA score. And a HRSA score is what determines the resources that you can access, for example, whether or not you have a HRSA for some things. For example, we have a lot of state programs where to be eligible, for example, like a loan forgiveness program, the individual would need to be working in a HRSA regardless of score. But on the federal level, a lot of the programs require you to not just have a HRSA score, but have a specific high enough one, for example, National Health Service Corps. One thing I want to point out about this slide is that the part of that formula that we can work with you on and the state can look at and see if we can, change and make more accurate is the population to provider ratio. The other three elements aren't ones that we can edit. They're from federal sources, they're from data sets. They're not ones that we can go in and change. So if you are in your practice working and thinking, I am experiencing a shortage, why don't I have a shortage designation? You can reach out to our office. You'll work with Anne. She will work with you to see if perhaps the providers are being overcounted in your area, or the boundaries of your area aren't accurate, or you should have a facility designation. There's all sorts of things she can look at and work with you on. There unfortunately are other things which we can't change. Those are set on the federal level. So if there was a question about like the formula and how to change that in general, that would be a question for HRSA, because unfortunately the state can't manipulate that. I don't know if it's unfortunate or not. I don't want to slam the formula, but here's a map of dental HRSAs in Minnesota. You'll notice it's from 2 years ago. We're going to be updating this shortly. The nation just went through a big shortage designation update for primary, mental, and dental HRSAs. So we were able to get all that data in by July. So we'll be updating these maps soon. They haven't changed drastically, but there are some differences. And just a bit about the process, which I touched on briefly. So it involves, a lot of partners. The community providers or clinics can contact our state primary care office. We will work with you on looking at that designation if you have questions about yours. We'll set up a meeting, emails, go through and see if there's any changes to the provider to population ratio, if there's a different way of looking at your area, if you need a facility designation, things like that. And then it is the federal partners at HRSA that will review it and decide on the formal designation status. So we'll make a recommendation, submit it through their system, they'll review it, and then the final designation will come back. We can always revisit them if it doesn't feel accurate, or if there is, this is the key thing, if there is a change in the provider makeup at your practice or within your area, good idea to re-review it. Contact us and let us know, like, we've lost a bunch of providers. We think we're experiencing more of a shortage. We can look at that and resubmit. Doesn't have to be on like a timeline or anything like that. If it happens 6 months after your last one, that's okay. But then it would go again to the federal office and they would be the one issuing the designation. That is all on HRSAs. I'm just going to pause here before moving into a brief overview of the rural health transformation work and see if there's any HRSA questions. Yes.
This one maybe goes back into your previous presentation.
Sure.
You were talking about active license methods and so on. I'm just curious, what's your definition of active?
Turfing that to Teri.
So that is currently active license. So it's a over estimate because somewhere in the neighborhood between 5 to 10% of dentists, especially dentists, less so assistants, dentist and therapist retain an active license, keeping them upon practicing. That doctors do that too. Yeah.
With that, so it's an overestimate, and then, some are inactive that maintain their life.
Yeah.
Do you know how many of them are actually maybe have a license, but they aren't physically located in Minnesota, maybe can keep it because they got family here?
We, yes, we do know. Indians actually going to be in that report. Yeah, we track, we're really, careful about tracking exactly where people are. And, well, not to get too deep into these, but as you know, some people might have an address that's in Hudson, Wisconsin, for example, but they move to work. And so we do our best to try to clean up those addresses and geocode them properly, but it's always yeah. That answers your question.
Yeah.
Just curious if you'll be sharing the slides on that. We're from rolling over here. Yeah, really valuable. Oh, good. Yeah, absolutely. Yeah, absolutely. I think that's right here.
Yeah.
To attract dentists to those, is there, is that a thing in dentistry? Like, so I was a national service, then payment one so how many of those spots are there for hot and so right there, like how do you get?
Yeah. Yeah, so that varies by year. I would say to have a National Health Service Corps provider at your site, you need to be certified as a National Health Service Corps site, which you'd also do through our office. The tricky thing is that then each year there is a different cutoff for the HRSA score that an area needs to have in order to get a National Health Service Corps provider. This year, it's higher than we've ever seen it. Dental sites need to have a 21. We are not seeing dental sites with a 21. It is awful. I do offer some hope. It does change every single year. We've had it quite low in past. And I can't offer a ton of insight into why, because I just don't know. It's a little bit of a black box trying to understand the scoring. But I would say 21 is a hard number to hit. It's also very, very rare to have that as the cutoff. In future years, I expect it will go down, in which case, if you are close, please contact our office and let us review the data with you. If you're interested in being a site that can accept those scholars, contact us. We'll review it with you. We'll see if we can get, if there's any inaccuracies that we could correct to get your score to a point where it will qualify to become one of those sites and then attract providers. Yeah, Nancy.
When does the new number come out?
21 just came out, so I'm gonna have to follow up on exactly when.
So we're not waiting a month.
No, it's about a year. Yeah. Yeah, sure. Yeah.
Yeah, 25% of has anybody done and then you show sort of basically slightly up graph, but it doesn't show the growth of the population, which is so if the population growth is higher than that, it's a negative.
Yeah, that's a good point.
So it would be interesting to see it with the population growth now, so you can tell which way it is. Now I'd like to see what if if you have 20 that have 25% in your survey, that is where is there a projection level relative to the population? You would think that that's going to give us what we really need.
That's
Maybe a local speaker.
Yeah. That, I think that's a really good point. We're essentially using.
Very trending, especially for rural, I guess.
Yeah.
Yeah.
I have a question just to understand someone better.
Sure.
There are three vulnerable designations. Can get one is provide the population provider ratio, the other is low income, and the third one is facility designation as well. So
So when you were showing the map,
Mhm.
it will overlay because one county can be a low income and also the geographic, and then maybe there are facilities. So how do we know that a particular county has all three of them? Because then it means that the whole proper county as compared to some other counties.
So it wouldn't overlap because you can't have two different designation types. That's one reason why when we work with a site, we'll see which designation is the most appropriate for your county. If it's a low income or a geographic, usually it won't qualify for both, but if it does, we will look and see if, you know, which score makes more sense for you. The best way to find out what your HRSA score is my favorite website, HRSA Find. You could just Google HRSA Find and enter your address. It will tell you all the HRSAs you're in, both dental, you know, oral health, mental health, you know, primary care. And then if you have questions, contact us and we'll just talk you through it. Yeah. Sure.
So like in the business or last year, like how many places were able to get in for one year? 5, 1 year?
Yeah, and I don't have the numbers on National Health Service Corps, but we can get those back to you. I would have to talk to another team member who's got those. Yeah. Yeah, Prasida.
So many of our partners, we don't know how to apply for the dentistry. And it's administratively challenging. Is there a way they can run our pollution of our program to get that designation sorted out? Because we are in the professional sort of area.
Right.
Designation, and I know you can use it. Some of the places that are really doesn't die.
Yeah, so it's not like National Health Service Corps where you're collecting a bunch of data and applying to get designated. We do a review of the state and designate all the areas based on the data we see. I think when you get in touch with us is if you are experiencing a shortage or looking at a program and wondering if you're eligible for it based on your shortage, contact us and we can resubmit your area for a shortage and see if it would then qualify. Yes, our office, the primary care office. And I apologize, I should have the contact info on here. But I will get that to you, Nancy, and you can send it out and I can make it clear who you reach out to if you have a question about your shortage. Yeah. You did, yeah. Yeah, that was, Anna's just a wizard on those details. We're always happy to come talk about it too, yeah.
Entity in any county to do this work? Is it like partners or is it like
no, usually it's a provider that would contact us because they're the one that's benefiting. So there's no person who like owns the shortage designation. It's a geographic designation or a, you know, area designation. But if you are located within it, anybody located within the designation can contact us and ask us to look at it. Usually it is the provider organization, partly because they're the ones that hold the data that we can look at, which is the provider data. All right, I did have a couple more slides. I think there was some curiosity about the Rural Health Transformation Program, and I can just give a kind of a high-level overview of that because I'm working on that as well. So Rural Health Transformation Program, just a little bit of background. It was signed into law on July 4th of 2025. That's what created this program. And it is the federal government administering $50 billion over 5 federal fiscal years. So it's $10 billion annually to be distributed to all 50 states. It's not an exactly even breakdown. So each state had to apply for your share of it. So MDH did submit an application to CMS last fall, and we were notified that we had an award on December 29th. So really exciting holiday season. We tried to design Minnesota's program with these guiding principles in mind. And I will say when we did the application period for this grant was historically short, but we did try to write it with these guiding principles and with feedback from partners, whether it was a public comment period, meetings with partners, meetings with provider organizations, things like that. All of that went into the program, which I'm going to touch on a bit here. So Minnesota's program is divided into 5 strategic initiatives, and each of these strategic initiatives has grant programs underneath them. So when I talk about activities here, what that means is a grant program. Some of them are grant programs that go directly to organizations that are listed in the application. For example, there's 90-something hospitals, 5 FQHCs, a number of CCBHCs, organizations that if you look through the application, their name is in there. So that's why you might not see a grant announcement for it this year. It's because it went to an organization that was named in the application that CMS approved to get that funding. Other ones will be coming out over the next 5 years as open competitive applications. So to get into the activities that we are going to be funding through this program, first initiative focuses on community-based preventive care and chronic disease management. So that's grants to support that kind of chronic disease management in partnership with community across that cardiometabolic chronic disease spectrum. The second, we have a number of activities focusing on the workforce. Recruit and retain talent in rural communities is the workforce initiative. That one does include some support for oral health providers, for example, support for rural clinical rotations. That was a competitive application this year that has closed, but it was open earlier this year. Third initiative focuses on sustaining access to services and keeping care closer to home. Some of the grant activities in that include support for frontline healthcare workforce, which includes community health workers, doulas. It also, that activity supports mobile units, which can be for physical or oral health going out into community. We have a fourth initiative on creating regional care models to improve whole person health. There's some grant activities there that focus on expanding telehealth into rural communities, support for maternal health, support for mental health. There's grants to create new children's mental health initiatives, new mental health urgent care centers in rural areas, and then a number of ECHO networks. And then that fifth pillar is the kind of more technology and payment focused pillar, where it's supporting provider systems, say if they need to upgrade their cybersecurity or their EHR or integrate AI into their EHR or prepare their FQHC for any sort of value-based payment system. Yeah, Nancy. ECHO is it's kind of a learning network where people can join a virtual learning network and get trained on the subject. So we've got ones on maternal health and I believe mental health that are funded through this grant. Yeah, sure. Those are the 5 areas covered under Minnesota's rural health transformation. As I said, there's kind of a mix of ways that you'll see it showing up. Some of them are direct grants. Some of them are competitive opportunities. Some showed up this year. We are just getting close to the end of our first year. You know, the award was made right at the, I like to say start of January. Technically, it was December 29th. But that's actually partway through the first year when we got the award. So this year really has been a standing up year and making some grants. You will see more opportunities and possibly different ones and, you know, different kinds of opportunities, more competitive ones in future years. We're getting ready to start years 2. We do, as a state, have to apply for this funding every year. So it's not a guarantee that we'll get that same amount every year. Obviously, we hope we will. But that is dependent on the progress that we're making, which is why a lot of these activities we have to report back on metrics and things like that. So I guess in sum, I would say there's a lot more to come and new activities to come with this program. We're just kind of wrapping up that start of it, and we're looking forward to continuing to move through it and build it over the next couple of years. I think that was our last slide.
So I bring you greetings from our program. Let's see if I can get this to work. All right, the clicker is not working. Is there another click that I got to do? We'll just do this.
You can just,
Okay.
that is kind of.
All right. I'll just use the, I won't use the clicker. I just wanted to talk to you a little more about, as Prasida mentioned, age-friendly care, how we have been implementing this type of framework in our educational activities, and I'll share some of the outcomes. I wanted to start with this, promoting age-friendly oral health care with federal support, meaning our HRSA grants, despite this. And, I'm sorry, I couldn't resist. I did check with my family and my coworkers, and they said they thought this audience would be okay. If it's not okay, I just blame it on the fact that I'm from Philly and I tend to say what I think. So I have a few disclosures, of course, my support, my sponsors for the various projects we do, including MDH, of course, the other foundations and Northstar GWEP, of course. And I do, we're not going to talk about any off-label stuff. I do occasionally accept gifts from patients. That's supposed to be me. This was a patient actually from a nursing home who was very happy with the dentures we made him and decided to give me this. Gave me a little more hair than I'm used to seeing. And I brought it home, and my wife said, "Get that out of here," because it creeps me out. She said, "Reminds me of one of those old Twilight Zone episodes where it's going to come to life at some point." And so I have it on my desk at the office. By the way, too, I do feel a little self-conscious because Teri kept talking about dentists over 60, and I felt concerned. Fortunately, she didn't talk about dentists over 70. So, this article appeared back in about 2017. Paula Spann writes for the New York Times and has a column ongoing series called The New Old Age, where she focuses on issues for older adults. I was interviewed by her for this article. First time I've been talked to by the New York Times, and when she called, I told her how privileged I felt to be interviewed by the New York Times, and she said, "Really?" This was in 2017, right after the 2016 election. She said, some people think we're the enemy of the people. But this article, is focused. I'd like to think that when things are showing up in the New York Times and in the mass media, there's something to pay attention to, and I think we all in this room know that oral health care is a huge issue for our aging population. I also see things like this coming out periodically, telling us that we seem to be doing a better, more successful at improving oral health in children than in older adults and in low-income seniors or low-income adults as well. So I think individuals who are low income, are in poverty or close to poverty, as well as older adults, are not seeing the same kinds of improvements that we'd like to see. And these are the reasons that are given, again, ADA data, for not seeing dentists in the past year. And its finances are the huge barrier that we know about. But there are other things too. I think locations, fear is still a factor for some people who just don't have natural teeth anymore and don't think they need any oral health care at that point, which of course is not true either. So perceived need, some of these issues are still out there, but by far the biggest challenge, I think, is finances and lack of insurance coverage. I get lots of emails from students This is one of our graduates from 2016 who's in North Dakota, approached by the community nursing home to start a satellite clinic for their residents, many of whom are non-mobile. They've met with leadership at the nursing home. The need's high. The patients keep asking when a dentist can see them. They weren't sure where to start. And she didn't really know either. She says, we're hoping you could advise on mobile equipment to use for their on-site exam room. Do you know of any funding available? So this is a new graduate, really, at that time of ours, who's coming face to face with the access issues being faced by older adults. Now, of course, the first thing I did was send her another copy of my handouts from the lecture I gave them on long-term care, because I talk about these issues, but I think when they're in the course, they may not be seeing the relevance of it at that point. Another one just coming in a couple of weeks ago, working in a small rural office in Southwest Wisconsin, again, having people return to the practice from a nursing home and finding lots of caries, and the teeth are falling apart even after having had restorative care. They don't want extractions or dentures with substantial out-of-pocket costs. Says they're concerned about diet habits, high caries risk. If you have any alternatives or suggestions, I'd appreciate it. Be happy to continue to correspond. So again, students coming out of our school who are coming face to face with the realities of geriatric care and the challenges. This, I think, is really, so I'm thinking about things now from the workforce to training perspective for getting dental professionals to be more age-friendly, to be able to provide better care for older adults. This is data from the ADA's clinical evaluators panel, who were surveyed about what makes treating geriatric patients more challenging than non-geriatric patients. And I want to walk around to see if this laser pointer works. Yeah, it does. Let me walk around this with you. 88% saying comorbidities, medical issues, making things challenging to take care of older adults, or more challenging. 68% cognitive impairment, and we'll talk about what we're doing to try to improve skill in that area as well. But then as you move around, you can see all the other kind of common issues that I think many of us who take care of older adults, home care needs, communication issues, transportation, as we kind of move around this circle, challenges with behavior and behavioral modifications, insurance and reimbursement over there at 31% of the panel, managing informed consent, and before procedures, also an issue. So again, those of us who take care of older adults are familiar with all of these, and these are the challenges that practitioners are reporting in their survey with the ADA. Oh, the clicker's working now. So why care? And you know all this. This is my latest summary that I'd like to share about what we know about oral systemic health and overall health associations. Obviously, quality of life, things like comfort, speech, chewing, food selection, food enjoyment, appearance, and self-esteem and socialization. So even data now out, and we're working on this, highlighting the influence or the association between poor oral health and social isolation, which is a huge issue of concern now in older adults. That is life-threatening to older adults. Turns out it's a bi-directional relationship. Social isolation and poor oral health, one increases the other. And so it's a growing area of concern, and we're actually working on some curriculum to teach dental professionals about that too now. But then we have these other systemic health issues: nutrition, diabetes control, aspiration pneumonia, endocarditis, cardiovascular disease, osteonecrosis of the jaws, and then this growing area of interest in terms of inflammation-mediated disorders, such as Alzheimer's. So our oral health services for older adults program, believe it or not, Dr. Helgeson, who trained in our program many moons ago, founded in 1981, 45 years. So I'd like to think the school was ahead of its time in trying to address these issues. And we're still going. Our mission, fairly simple: training dental and non-dental professionals. So it's also non-dental professionals. We have a lot of strong relationships in the community, medical systems, our academic health center, to provide training for those individuals too about oral health care for older adults, contributing new knowledge through some research and scholarship, and improving access through our own clinical services that we provide. We are now combined with our former GPR program, working out of the special healthcare needs clinic over on the 6th floor of Moose Tower. And we have 3 fellows in training with us now. And they are part of our hospital and special care dentistry program, recently officially approved by the Regents of the University of Minnesota. So we are teaching them a combination of not just geriatric care, but also care for other special needs populations. So intellectual developmental disability, sensory impairments, other types of concerns, as well as hospital dentistry. So people who are either sick enough or have significant behavioral issues and require hospital care. Our mini residency has taken on an interesting prominent role in our educational activities, and this is where we first were able to connect with MDH through their HRSA grant, their grants to states that Prasida has talked about. We started this program, believe it or not, in 1991. So this was our 34th year or so last year. This was the class of 2025. You can see in the map over there all of the places in red that we've had trainees from throughout the US, Canada. We have a few states that haven't sent anybody. Yeah, I'd like to see why that is. My theory for Wyoming was they just don't have any dentists there, but I don't. Anyway, yeah. But also folks from around the world as well. So we've now had over 400 folks from 47 states and 6 provinces of Canada doing the course. And as I say, that's became a kind of a natural intersection for us with MDH when they were looking to cultivate age-friendly care and promote that through more training here in Minnesota. These are those 4 M's that Prasida introduced earlier. This is the age-friendly health system framework that was devised and initiated or launched by the John Hartford Foundation and the Institute for Health Systems Improvement, as well as a few other partners. Believe it or not, this model is almost 10 years old now. It was rolled out in 2017. And I suspect that there may be even a few people here in the room who hadn't heard of it before. But it is a nice framework that we are using, not only those of us in the oral health, geriatric oral health field, but throughout medicine and other health disciplines, including all of those that are engaged in our geriatric workforce enhancement program, which is also a HRSA-funded grant to the University of Minnesota. It's based in the medical school, but involves all of us throughout the academic health center. So the 4 M's, now, by the way, there are a few folks out there who like to add a 5th M, and I'll tell you about that in a minute. What matters? Trying to make sure that the care older adults receive aligns with their own values and priorities. essentially ensuring people get what they want, not just what we think they should have. Medications, those of us, again, who've taken care of older adults a while know medications are sort of a double-edged sword for older adults. They can certainly help with a lot of problems, but they can cause a lot of problems. And so one of the principles or the M's of the 4M framework is to make sure that medications are appropriately used, that age-friendly medications are selected, and that they don't interfere with all of the other M's that we're trying to accomplish, things like mobility and mentation and what matters. Mentation, which is actually again, I sort of like the designation, not just mentation, but mood and mentation, because there's a tendency for people to think mentation just refers to dementia, but it actually refers to depression, it refers to delirium, it refers to other disorders of cognition or mood that may be a common concern in older adults. And so we're trying to help identify individuals who may be having difficulties in this area and manage their dementia, depression, delirium across different settings, including the dental setting. Are we going to treat this ourselves? No. Can we help recognize it and refer people to the appropriate resources? Absolutely, yes. Absolutely, yes. And then finally, mobility, ensuring that older adults move and can move safely every day to maintain function and allow them to do what they think matters. Again, people say, well, how does that affect the dental office? Well, I would argue that, again, we're in a position to recognize individuals who may be developing problems with mobility, and we teach our students now about screening for that. We also are concerned about having people move safely in a dental office, so safe patient handling, being able to transfer people safely from wheelchairs to dental chairs or back is important. Recognizing fall hazards in the dental office. All of those are part of the mobility spectrum. Now, the fifth M I mentioned that some of my geriatrician colleagues like to mention is multi-complexity. So multi-morbidity, the fact that older adults tend to have multiple chronic diseases and things. Somehow that didn't make it into the 4 M's, because then it would have been the 5 M's. But I think that's, I guess, I don't know. I don't know why it didn't make it. So that is the 4M framework. That is a nice way to organize what we're trying to teach various learners to kind of get our workforce prepared for this growing number of older adults. So our first exercise or project with the Department of Health with their HRSA grant was to incorporate the 4 M's and sort of redesign, rebuild our mini residency to incorporate the 4 M's framework and organize our material in that way. You can see our objectives here, just recognizing the challenges and characteristics inherent in geriatrics and long-term care settings, strategies to plan and implement effective dental programs for older adults and in long-term care, managing the clinical challenges we see, general health problems of older adults, as well as the common oral health concerns we see in that population, and then again applying the 4 M's framework as a way of organizing this educational activity. Some pictures from our 2024 course. This was in May, and we actually ran this course with some support from the MDH and their HRSA grant to provide scholarships. We targeted rural practitioners for this course. Again, a focus of MDH in their project. And we actually, through the generous support of MDH, gave scholarships to 7 practitioners from rural communities in Minnesota around here to take the course. So that's our class picture, which we do every course. some pictures from our safe patient handling training, some of the speakers, including Merrilee Johnson, who is a long-term care administrator, who comes into our course to talk to our participants about the world of long-term care and what their dynamics are, what their challenges are, why people might not be getting their teeth brushed, and what the pressures that they're under these days. We also implemented, as part of the HRSA project with MDH, a pre-test, post-test. And we're able to collect some data. So MDH, again, generously helped us with some evaluation support to analyze this data. We gave our participants starting at that course, a 12-question pre-test and then a post-test. And we pulled out here some of the data indicating, so the question, again, there were 12, that we had 17 rural care providers enrolled. 15 responded completely to the tests. We had 53% answering the question correctly about decision making for patients which is the first one here, but post-test 100% getting it right. Managing behavioral problems, 20% right these are again just 3 of the 12 questions. Improving to 80% on the post-test. And then a question on drug therapy, 7% getting it right on the pre-test and 93% getting it right. So looking at the summary down the bottom, you can see, again, a mean score going from 6.87 up to 10 out of 12 or so on the post-test, with a improvement, a size effect of that improvement being over 2 standard deviations according to Cohen's D-test. So we think we taught them something. And they knew more about geriatric care. Now the question is, of course, how do we get more people to do this? Because we need more practitioners. But this is where support from partners like MDH come in handy, because the fact is, this is a 4-day course and it requires practitioners, and it's open, by the way, of course, to all dental team members. So dentists, dental hygienists, dental therapists, dental assistants. We've even had office managers and other administrative staff come to some courses. But it's a big investment. There's tuition, there's time off from the practice, might be hotel room and all these other things if they're coming from someplace else. So making this kind of training accessible is a key issue that we need to deal with to get more folks to do it. I just wanted to give you a heads up. We are continuing to offer the course. This is our next offering in November. We're revamping it a little bit. We're still got the geriatrics component in there, but we are adding in some other special needs populations who are also suffering from lack of access to care. So folks with intellectual developmental disability, folks with psychiatric disorders, folks who have serious medical issues, people who might need hospital care. So I'm teaming up with my colleagues over at in our Division of Hospital Special Care Dentistry, Dr. Mark Rutger, who was Chief of Dentistry over at Fairview, and for us at the University of Minnesota Medical Center, and Natalie Jones, who is our Hospital Special Care Program and Clinic Director, to teach this course in November. So one of the questions we'll have for you is whether you have any scholarship money for this. Okay, good. You heard her say that. I want to finish up here to talk to you a little bit about our work with the GWEP, the Geriatric Workforce Enhancement Program. One of our projects with them was to focus on dementia care and how to improve that. Again, some of the emails I get, this is someone who works with family caregivers, looking for dentists that work well with people with memory loss. Here's another one. This was a daughter who eventually did bring her mom in to see us. We're talking about the fact that she had Alzheimer's. She had read about some of our work through some of the media that's been out, news stories on some of the work we've been doing. Resident in a memory care facility with advanced Alzheimer's. Mom broke a tooth. Looking for in-house care at the facility, coming up empty, she says. She requires a lift for transfers. No longer able to transfer for appointments. And she would want someone who was more skilled at dementia care, wondering if I had any suggestions. And of course, she came to our clinic where we had all those capacities, not only to manage people with dementia, but also to do lifts, mobile mechanical lifts. So the Dementia-Friendly Dental Practice Initiative, which was part of our HRSA grant with the university for the GWEP, we also enlisted support from these other sponsors. So it's not just the GWEP, but Act on Alzheimer's here and our Area Agency on Aging. Now, the Metropolitan Area Agency on Aging changed its name some years ago to Trellis, and they have recently changed it back to the Metropolitan Area Agency on Aging, because they, like others, must have realized a lot of people had no idea what Trellis meant. And I remember telling Dawn Simonson, the executive director, that in the beginning, and they finally have come back, and it's now the Metropolitan Area Agency on Aging again. So they've been a big booster. Of course, the School of Dentistry, the Minnesota Dental Association, incredibly helpful in helping us not only enlist practicing dentists to give us feedback on this curriculum that we were working on, but also in helping us get the word out, disseminating it, and even helping us set up trainings for various district dental societies around the state. Delta Dental provided some startup support for the project too, to help us get some of the work done that we needed to, and the Barclay Group, which is a local group of dementia consultants, worked with us as well. We wanted to define a dementia-friendly dental practice, create a sector guide. So what does a dementia-friendly dental practice look like? What does it do? What does it not do? Developing a clinical practice tool. So a quick reference for use in the dental office when people are managing or clinicians are managing dementia. And then developing some basic and also advanced training. So we wanted to provide some basic training for all staff, including administrative and office staff, as well as more advanced training for the clinicians in the office. Here's our definition that we developed of what a dementia-friendly dental practice should be. It provides person-centered care to oral health care for individuals with cognitive impairment, promoting timely diagnosis. So that involves being able to do some basic screening and recognition, facilitate connection to community resources for patients and their care partners. We recognize when we're taking care of people with cognitive impairment that there are often care partners who are helping them, who are a crucial part of their care, and who are often under stress and need support too. So you don't have just one patient there. I'd like to tell students we've got at least a couple, because you've got a care partner you need to be concerned about as well. This is Dementia Friendly for Healthcare, a basic training program, hour to an hour and a half, can be delivered in person or online. It is actually run by the Area Agency on Aging trainers, and it is meant to give all members of the dental team or other health professionals working in medical offices a basic idea of how to understand folks with dementia, how to communicate better, how to understand some of the behaviors and things like that. We then also developed our advanced training program. This is the title slide from one of the courses I ran for the Northwest District Dental Society this past year. We've been up to the Northeast District Dental Society at MDA as well, training their folks, as well as other audiences. But I think the title of this that I picked says it all. We need more dementia-friendly dental practices because we are now heading toward 200,000 individuals in Minnesota and about 7 million nationwide with dementia, and that number is growing. And I tell our students and CE audiences, you're not going to be able to just find another office to send them to, because there aren't going to be that many that have specialized training. You're going to have to do this care, and you can do most of it. Most patients we see don't need to be referred out unless they have some extreme difficulties from their dementia. These are the modules that are included in the advanced program. We have identification and assessment as the first module. That includes, and this course includes a couple of videos. When we were meeting with our team, I told them I wanted not just to tell people how to do this kind of care, but show them how to do this kind of care. And we were fortunate with the funding that we had to film a couple of videos. The first one on how to communicate, have a conversation about concerns about dementia or cognitive impairment with a patient and their care partners, as well as how to do a basic screening, a mini cog, to screen folks for dementia. We have a module on environment and safety, decision-making capacity and consent. How do you go about assessing decision-making capacity? And again, we were able to film a video with real patients with dementia to show how that's done, how you have that conversation. And then patient management, treatment planning, and finally a module on patient and care partner support. This material is now accessible through the Act on Alzheimer's website. We've got a web page there for dental providers, which has links to all of these resources. This is what you'll find. You'll find links to Dementia Friendly at Work for Healthcare training, which is that basic hour to an hour and a half course for all dental staff, as well as links to the advanced training program. Our clinical practice tool, which is that quick reference guide, is on the lower left there, as well as the videos that we filmed are posted there as well. Here's what we've been able to accomplish on this project, again, with the generous help of the GWEP, and has been incorporated into our work as well with the mini residency and the other trainings that we're doing with MDH, because this, of course, dementia-friendly training fits squarely within the mentation realm of the 4Ms. You can see we've now provided advanced training to about 340 or so dental professionals around Minnesota, including dentists, hygienists, assistants, some administrative staff. We had a couple of nurses do the training and even a physician do the training. This is, and the focus of our final couple of years of our HRSA grant was to take what was a live course on dementia-friendly care and turn it into an online interactive course. We were able to support an educational designer to help us do this. So this course is now available on the U of M CE website. Because it was developed with federal training grant money, it is free. Unless you need CE credit. So anybody can take it free. And I've actually had inquiries from even dental schools now about incorporating these modules into their curricula. Yeah. And we are, and so it is free unless you need CE credit, in which case it's $50 a credit for up to 6 CE credits. We've gotten some nice coverage for it from some of our work, including this nice article from TPT's Next Avenue, and some pictures of some of our trainings up at Northwest District, and our first pilot practice out in Stillwater, South Hill Dental. Our sincere thanks to the Department of Health's Oral Health Program for their generous support of our work, as well as the Minnesota GWEP, which is, again, supported by HRSA. I know we're at lunchtime, a group of my happy patients. I'm happy to chat for questions, or we can just chat at lunch, whatever Nancy and Prasida think is best. Thank you.
everyone for being here today. Thank you to the Minnesota Department of Health and to Nancy, to the Minnesota Oral Health Coalition for allowing us to have a few minutes of your time today, just to talk a little bit about what we do throughout the rural parts of Minnesota specifically. Our role really is described in the handout that you have on your tables there that I just gave out to you. But really what drove home some of the information that was shared today were the slides from Dr. Fritsma and Laura. It just speaks volumes about the need for the roles that we play. And I'm not tooting my own horn here. I'm not talking about me specifically, but just the role that each of us does in rural Minnesota to help support oral health. You know, in short, we're kind of the face of oral health in rural Minnesota. So most of us come from pretty small departments. There are many, many different hats that are worn by the public health workers and the staff, the educators, things like that. And the portion that often is dedicated to oral health is a very, very small portion of their time, right? And so for us to be able to dedicate a lot more of that time to specifically oral health really speaks volumes for the work that has been done throughout the state. We really are kind of the squeaky wheels that keep squeaking and squeaking and, you know, sharing what our needs are. And I think Dr. Helgeson, if anybody here in this room can vouch for us being the squeaky wheel, it's probably Dr. Helgeson or Nancy. We're constantly calling on Apple Tree or Caring Hands or Children's Dental or any one of the other many providers that we have throughout the state to say, hey, we have some really significant needs here in rural Minnesota and in our specific communities. So that's really what this handout, the handout that we have given to you today, talks a little bit about. I'm going to turn it, we're only up here for about 15 minutes. We think we cut it down to 14 minutes now with lunch. So, but I'm just gonna let each of my counterparts here talk a little bit about some of the specific things that they do. And then I'll come back for our final slide just to kind of talk about the face again of oral health in the rural communities and what our oral health stories are. So I'm going to turn it over to Alex and he'll go from there.
Awesome. Thank you, Jane. My name is Alex Orvik. I'm the dental coordinator for Region 1, which is in Northwest Minnesota. So on the slide, you can see all of the 3 regions that we're in. I'm in Region 1, Region 4 is Jane, and then Region 7 is Tessa. So we all cover a different part of the state, and we all do very similar things, but also very different things. So what I'm going to touch on is my work in Northwest Minnesota. So I have 2 maps here. We have 2022, which is before I started. We have our safety net clinics there. You've got Grand Forks, North Dakota with Spectra. Then you've got Northern Dental Access Center in Bemidji and Halstead. And then the next map is since I started. So as the dental innovations coordinator, what I really want to do is I want to create those access points. I wanted places for people to go and get dental care where they're at, whether that's in school, in their community, anything like that. And with these mobile clinics, we're able to provide restorative services as well as hygiene. And currently, my numbers are right. We've seen 402 kids just with the school sealant program alone in Northwest Minnesota. And that number has increased again. We're continuing to add more and more schools. It's fantastic. We've served 239 kids in our hygiene mobile clinics, and then 145 kids in our restorative clinics. So this is just something that I've done in Northwest Minnesota, and I hope it can be replicated across the state. If not by a dental coordinator, by someone in public health. But with that, I'm going to turn it over to Tessa.
Hi, everyone. Tessa Wilhelm. I'm with Benton County Public Health. So think St. Cloud area, central Minnesota. And most of the work that I focus on, a big part of my work is just that community outreach and promoting oral health and the importance of dental care. And so while I'm out in the community, being that boots on the ground person, getting to interact with the community and provide that education, answer any questions people may have. I also have the opportunity to provide oral health material. So giving them those toothbrushes and that toothpaste and the floss to promote those healthy habits, I think is really important because just a quick little story. My first outreach event, I was really eager. I was giving out toothbrushes and the amount of kids that were so excited to receive a toothbrush because at home they didn't have a toothbrush really hit home to me. And I was like, this is why we do what we do. So getting to go to those outreach events and give people those toothbrushes that they don't have at home is really important. And then as you all likely know, there's often other underlying needs. It's not just the toothbrush, but maybe they need access to food as well. So getting to be that person that also shares those other resources, because as we know, oral health impacts overall health. So getting to give them resources to maybe have access to healthy foods is also super important. And I'm able to help with those connections as well by being that person in the community. And then just kind of to wrap up, each of our communities is different. So we get to focus on the needs within our community. And like Alex, he focuses mostly on those mobile dental clinics. Jane focuses a lot on her early childhood dental network. And then me doing that community outreach. We all do a mix of that, but just looking at that data and seeing what's needed in those communities, and then having those community stories as well to, just kind of drive home why we do what we do. But we live and work in the communities that we serve, so we get to see those needs firsthand as well. And then we just get to be that familiar face within the community, and just be that connection point and really get to be that person that people can call, and we get to be that warm handoff to the dental clinic or maybe to the other county services, whatever those people may need. Yeah, and I'll hand it back over to Jane.
Thank you, Tessa. So again, you're just getting a little snippet here of the work that we do. And in Alex's case, I just wanted to point out something to all of you too, that we are so rural in Minnesota in some cases. When he talks about serving 400 kids or 200 kids or 150 kids, I have counties that literally have less than 200 children born each year. So that is where we live and work every day. And the resources are quite scarce, right? And so without Alex there, how would those kids be getting the care they need? So when he talks about 400 kids, that's huge. Apple Tree, we were able to just get an outreach clinic up and going in Detroit Lakes. And we just met last week. I'm drawing a blank on the numbers at the top of my head right now, but I think it's 1,800 and some visits that have occurred there in the last less than 2 years. That's a huge percentage of the people that we are serving day in and day out. So I realize that those numbers don't always sound so incredible when we're living in, or when we're, visiting the metropolitan areas, but in our rural counties, those numbers are really, really huge. So again, our little handout that we have here is something that we actually developed and shared when we went to Washington, D.C. Nancy and I had the opportunity to go there to do a visit on the Hill. It was pretty fun. It was pretty exciting. And again, we look like a pretty small fish in a big sea when we're in Washington, D.C. But we really started a lot of the conversations with, what's your dental story? And I encourage all of you, it was pretty fun, actually, when Nancy, when we talked about it. So we met with one of the younger staffers and we sit down and, I said to him, I said, so what do you know about dental? And I mean, of course, he looked a little like, well, what do you mean? What do I know about dental? And I said, everybody has a dental story. What's yours? And he proceeded to tell me how he was a hockey player from out east and ended up getting his 2 front teeth knocked out playing hockey, and how fortunate he was that, he had new teeth, of course. And I just really asked him, I said, where do you think you would be today if you didn't have those 2 front teeth replaced? And he, again, kind of looked at me and, well, I don't know, I probably wouldn't be here. And I said, that's exactly what we're living with and dealing with in rural Minnesota and all of Minnesota, really, in many parts, whether you're a senior population, a young child, or, whatever age you are. But that's really the purpose for this slide today. And I know I'm preaching to the choir here. I know all of you are, very well versed. You talk dental, you're always talking about teeth and things like that. But in your day-to-day communications, I have just found that it is super impactful to get people engaged in the discussions. When I ask them first, what's your dental story? And, Nancy can vouch for that. Every single person that we asked that had a story. Maybe it was her nephew. Maybe it was her grandparent or whatever the story was, but everybody has a dental story. And so I guess I would just encourage all of us to do that in our day-to-day conversations, because
when I retire someday and when I'm about 100, my goal is going to be that we don't have to talk about oral health, but that we just talk about health. The same way we talk about if we have a headache or a broken arm or we're suffering from some kind of a stress related illness. I think they've come a long way with mental health and tying that into oral or to overall health. And I would really, really love to see that same progress made in oral health before I retire at 100. So anyway, feel free to reach out to any one of us. We love what we do. We're here to visit with all of you and to share the word and the information about what we do. So thank you all. Anybody have a question or anything? No? I'm sorry. Okay, perfect. Thank you.
Yeah, it was really fun to do Hill visits with Jane because she started asking everybody. And we were in a congressperson's office who wasn't really friendly to us. And Jane started out with, well, do you have a dental story? And boy, you could just see everything kind of break away. It was really, I've been sharing that with a lot of folks. I'm like, that's the way to get it going. Do you want to do that?
No, take the next.
Oh, okay. So thanks, you guys, and thanks for the work you do. And I think what's really important too is that you're embedded in public health departments. And I love that model. I mean, that is such a great model because I call it cross-pollination, you know, when we can have public health and dental, oral health talking together. I'm really happy to introduce our next presenter, Dr. Ann Zukoski. She is the Director of Healthy Aging, Long Range Planning at the Office of Minnesota Management and Budget. So welcome.
Thank you.
The pointer? No, it's too
You can just,
pointer is too complicated.
you can just do it.
I'll just press my button. Thank you so much. Good afternoon, everyone. My name is Ann Zukoski. I'm a public health person. All my training and background is in public health, so I love shout outs to health departments. How many of you know what MMB does? Minnesota Management and Budget. Ooh, couple of hands. Well, I'm going to do something here. I'm going to make your brain work. I'm going to advance a slide that has a question for all of you that I'm hoping to get a few shout outs for. And then I just want to say something about Minnesota management while you're absorbing the question. So you have to absorb the question and listen to me. It's like a thing. Okay. So, Minnesota Management and Budget is in charge of the whole enterprise of the state government. So 56,000 employees. It handles HR, all sorts of things, right? I think you might know it the best because it does the budget projections every year of like what is our tax base bringing into the United States, into Minnesota. Part of MMB includes a policy and planning division, which looks at cross-agency work, right? So how do we get our state government to work across our agencies and focus on key issues? And that's where I come in. I'm an employee of the Minnesota Department of Health. I work with Deca, with Prasida, with Eleanor, with lots of people in this room, Bilkas. But I'm on a one-year mobility assignment. So meaning I am working at MMB for 1 year in the policy and planning division as part of a long-range planning team. So I wanted to just tell you something that Minnesota used to have a long-range planning agency from the 1960s to 2001 that thought about 30-year visions of where we were going as a state on any number of issues, water, oral health, any number of things. In 2000, it was dismantled and there is no longer a planning agency. In 2023, there was the startup of a small group called the Long Range Planning Team, and that's where I'm based. So I just wanted to give you some grounding so you understand where that's going. So you had a chance to look at this question. Does anyone have a great shout out of thinking 30 years into the future? What does the landscape of oral health in Minnesota look like? What will have changed from present day? And I think what I want to say is, what do you want the landscape of oral health to look like? What do you dream the landscape would look like?
We won't be counting dentists.
We won't be counting dentists. That's like central to that we have dentists throughout the state serving everyone.
That is actually the care, access to care, or health wellness. They're all not dependent on where the dentists are, how many dentists are there, that health services will be accessibility. So many different avenues, and so many prevention will be going on. That surgical intervention might be high skills that be as provided.
Got it. The prevention is paying off. Okay.
Collaborative practice management and dental therapists who are able to cover more areas because they can't do that, but that also involves us collaborating with private industry too, and letting them know, like, you can have these smart classes, you don't have you know, and so I think that would be really great is just more knowledge and collaborative practice because it allows more growth and more access to care around the state. So that's what my little brain knows. And also because it's really healthy team that I don't
Yes.
well, I won't be quite 100 yet in this year. My goal would be that it's all integrated.
Mhm.
That's aggregated oral health care and mental health care and physical, that would all be one integrated.
Wonderful. So those are some great visions, right? Of where we think, where we want to go, and then actually how do we get there? And you have to sort of call it out, right? Reach some consensus on it. And in the role of the long-range planning team is to think beyond the biennium, think beyond a 2-year budget from the state, to think more long range. And you know, that comes with challenges, as this room knows, with politics, with all sorts of things. So I'll come back to this idea of a 30-year vision and implementation, but I just wanted to provide some information to you today on some work that Minnesota Management and Budget is doing on healthy aging, outline the approach we're taking, and then share how you can help and invite you to participate in this effort. What I want to say is that my work is all, this 1-year mobility assignment that I'm on is all due to a special appropriation from the state legislature to MMB to explore healthy aging and how can our state do a much better job at advancing healthy aging. And we are really focused on implementation. So let's just go to, oh gosh, touchy computer. So just thinking about just taking ourselves back out to healthy aging overall, you know, what do we know? We know that our state is in a permanent shift in its demographic makeup, that we have an older population. We know that we are all aging. We know that there's great diversity amongst communities, within communities, on how we think about aging and about how we all want to age and what that will look like and how we want it to look like for ourselves. We know that there's a huge commitment to thinking about healthy aging in the state. We're very lucky. We have Minnesota Board on Aging, which thinks about this. We have Age Friendly Minnesota. We heard about the 4 M's of age friendly in healthcare. So we have GWEP, we have your program. We have Age Friendly Minnesota, which is led by the Department of Human Services, thinking about this. And of course, all the partner organizations and all of the work and all of you in this room, right? Thinking about aging. And we have a long history of planning. We have a lot of plans. I think I'm hearing in this room much more doing and action than planning. But I will say that government entities tend to plan. The challenge comes with implementation, like how you follow through. So we can pilot programs. Wonderful work is going on with that. But how do we take that to scale? How does it become permanent? How do we advance that? And I know that that's the point of this gathering, is to think about those things. What we are acutely aware of, and those of us who worked in government and battled in it, and those outside of government who think about it, that it's really hard to coordinate with public-private partnerships. It's hard to coordinate across agencies. It's hard to tell a holistic story of the work and advancement we're making. I've actually learned so much from these convenings over the last couple of years about how to do that. And I think it's well evidenced here. And then finally, just community voice. How does community voice get into government? How are we responsive to government, held accountable to government, is really something that is another challenge with these plans. I think that we see a lot of opportunities right now in healthy aging. There is some momentum. 3 years ago, there was a legislative task force on aging trying to look at what would be one entity to lead or advance healthy aging in the state. And out of that 1.5-year task force, a number of recommendations moved forward. There was not political will, which is very important when it comes to policy, to create an agency on aging or even create a subcabinet. So what happened is that this appropriation was made to MMB to keep thinking about it. And so that is one effort that's going on. I want to point out that also the Board on Aging right now is completing their state plan for the next 5 years for aging. And Age Friendly Minnesota is also advancing the work of 9 action teams to advance implementation. So there's a lot going on in this state. All of the efforts are slightly different, but they're all going the same direction, which is that we want to make Minnesota the best state in which to age. And really, I'm really heartened by this work and the thinking of it. So I want to just say more about the charge to us. Gosh, I'm not very good at pressing buttons. Okay. So we received an appropriation to complete a multi-sector healthy aging plan with a focus on implementation that seeks to support Minnesotans and Minnesota communities with growing populations of aging adults, to think about aging across the lifespan, that we can't wait until 50, 60, 70, 80, 90 to think about this. We need to start thinking about it much earlier. And to promote and incorporate the voices of the public and older adults and their families in this effort. And really with the long-term goal of making this the best state to age in. The purpose of our effort at MMB, we have 1 year. We are making specific recommendations to the legislature. And what we're trying to do is create a plan that will strengthen and transform state systems to improve strategies, policy, programs, incorporating community voice. And the way that we are doing that is thinking about a couple of questions. We've gone out and had a lot of community conversations, and what we've come back with is that in order for state government to move forward, we need to think about a number of things. So one, if you look at the green box, sort of what is a definition of healthy aging that we can work with? What is a systems-focused definition? What is a definition that incorporates community level change as well as individual needs and services? What framing can capture the good work that's going on now, elevate that, and help us look at the gaps and where we need to go in the future? How can we have a picture of this work? What is the current state of state government and what is the future? So what are we doing right now? Can we map that out? We don't even really know when we look across all our state agencies. And then what is the future state? What could the future look like? What matters most? We want to know from Minnesota population, communities, current and future older adults, what their priorities are. Where do we need to start first? And then how do we get there? So what are the models to make state government do its best work? What will support implementation of policies? What will support better implementation of programs? Reduce fragmentation, move us forward? And how are we held accountable to the public and to ourselves, right? We're all taxpayers too. And how do we measure progress? We are looking for sort of moving to the blue box, the short-term gains, like what are the emerging opportunities right now that we recommend the legislature invest in that will turn the dial, that will help us move towards that 30-year vision? And so then what are the next steps? What recommendations can we make to the state legislature that are not just high level recommendations, but include an implementation plan of what are the next steps. What is the role of the legislature? What are role of state agencies? What is the role of community? Like calling those things out with the idea that perhaps that leads and prompts action. I'm gonna take a breath. Oh my gosh, that was a long sentence. This is our approach. From January to March, we've been having cross-sector conversations, talking to the community, sort of pulling together our plan. We're conducting research right now into frameworks and definitions. We're mapping state agency work. We're holding community conversations, looking at, so much work has been done to collect community voices. And we're looking at those implementation models. Who in state government, who in other states, who in other countries have done this well that we can learn from. We're pulling together a healthy aging guidance group that will support, review, look at the opportunities and gaps, and then help us surface what needs to happen next. And then we'll be making final recommendations with that implementation plan. And we're really trying to gather emerging strategies and action pathways. So here, I'm hearing an action pathway. How can this work of dental integration specialists, and you might be getting the name wrong, but like, how does that scale and grow, right? Because it fits so many needs. We formed a guidance group, and I'm not going to really go into that detail, but we're trying to bring together bold new voices, people who are thinking about this issue differently, people who can think 30 years into the future. It is hard to think 30 years from now. It really is. Where we see this plan making a difference is that we think we can create a framework for decision making. We can take a whole government approach. How do we have aging in all policies? Thinking about these action steps, very concrete action steps. We'd like to think that we are working in partnership with our state partners to clarify roles and priorities, to highlight opportunities for alignment and identify starting points. And then finally, for the community, we are trying to bring community voice into the process. And we hope that that will lead to improved alignment, coordination, and equity. And I think it already has by bringing agency partners and community partners into the same room. We've seen advancements and changes that are happening naturally, but because of this process at MMB, it's sort of accelerating too. I think we're just trying to keep the momentum going, the conversation going, the sense of urgency going. So I'm coming back to our 30-year picture. And I think the question is, what is that 30-year picture? And then what are the steps to get there? And what are those implementation steps? And I think that many people in this room have these ideas. I'm going to invite you to share those with me and with the team, and we're going to try to work that through with the guidance group. I'm not sure where we are in time. Where are we in time?
14.
Oh, I have a lot of time. Okay. I don't have that much to say because I'm a fast speaker. So
You can be done whenever you want.
thank you very much for that. No, we can open it up a little bit for discussion too. Press the wrong arrow. My apologies. So how can you contribute? This is a QR code. If you want to, you can share your comments. We're asking people to share their comments and that they will be kept confidential. We have a survey that'll be coming out. Yay, another survey. But we're asking professionals and those passionate about aging to complete it. We will share it with the conveners here and have it go out, spread out. If you answer the QR code.
Older adults in long-term care facilities. Dr. Michael Helgeson is the Chief Executive Officer of Apple Tree Dental. And Dr. Lyubov Slashcheva is the Chief Transformation Officer, Research Director, and Dentist at Apple Tree Dental. Please welcome them.
Is that yours? I think that's yours.
Yes, that's it. Yay.
So you can just use this one.
And what's the trick just to push that?
I don't
button?
think that is working.
That's not working.
Yep. So we just use this one. Just over here.
Oh, just with your, oh, okay, cool. So you gotta use two, yeah. All right, well, great. I'm Mike Helgeson from Apple Tree Dental, and I'm excited to team up with Dr. Slashcheva and talk about two things. And if I can push the button here. Nope, it's not working. Yeah, I'm trying to click it on the slide. Pushing down on the bottom.
Pushing down.
Okay, all right, very good. Okay, two things, a little bit about Apple Tree Dental, hopefully a little less than 5 minutes will be my part of it, and then talk about our role in this HRSA-funded grant project and share some of the outcomes. So a little bit about Apple Tree. We're a nonprofit organization. We're a critical access dental provider, and that's a really important category. These are providers that are really committed to providing services to folks that face barriers to care, including older adults and everyone across the lifespan. You can see from the little map that we're treating patients from all 87 counties. The darker the shade of green, the more patients from those areas. And we bring care into long-term care facilities, memory units, schools, Head Start centers, group homes for people with disabilities. We're on a mental health campus. We're in a couple of rural hospitals. And actually, about 2/3 of the care that we provide is in greater Minnesota. Our model of care is called community collaborative practice. And we heard several of the speakers talk about collaborating with communities, and really that it's through a collaboration with all the different players in a community that you can design oral health services. And that doesn't equate to dental offices. So oral health is a team sport. It can be done in school, it can be done in a group home, it can be done in long-term care, in lots of different settings. So 3 kind of key things is that the model is proactive. So we're really delivering oral health care rather than providing access to a dental office. So it's kind of flipping the model on its head. And it's actively engaged with whole person health. So working with medical, dental, educators, mental health providers, things along those lines. And the whole idea is to integrate dental care into total health homes. So someone mentioned where you don't really have to talk about oral health, that it's really a health home, and there's a room in it for oral health. So that's so in long-term care, it means bringing assessment, prevention, and treatment into the facility, connecting directly with the residents and creating a long-term dental home. So our centers for dental health are clinics. We have mobile programs that operate out of those, and it's a hub and spoke model. And it's a cloud-based system that integrates telehealth with mobile health with clinic-based health. So we can reach out with all those modalities and get to people where they are. We use mobile offices where we can bring in more complex care. We have lighter units that hygienists can carry in without a full office and do a lot of preventive services. And we have a team of care coordinators that work with the staff at each of those sites to create effective days of work taking care of folks in those homes. So with that, I am going to turn it over to Dr. Slashcheva.
Thank you. So we were so excited to collaborate with Prasida and her team on this HRSA grant on 2 separate projects, so you could call them pilots. The goal was to figure out what are the pieces of this age-friendly health system that we would like to integrate into a oral health promotion model in long-term care settings. So we asked 4 main questions to develop the model. What are the existing oral health policies, processes, challenges, and opportunities within long-term care facilities? The second question, what are the caregivers' practices? What is their capacity and readiness to support oral health of the residents? Thirdly, what are the needs of the residents in regards to oral health in the long-term care facilities? And then lastly, what are the factors that influence scalability and sustainability of an age-friendly dental public health model in long-term care facilities? And what are the barriers and facilitators there? So the 3 main components of our pilot were first a needs assessment, training the trainers program, and lastly an outreach pilot to actually do some screenings and coordinate care for oral health needs. We focused on rural dental HRSAs and of course residents in long-term care facilities. So the needs assessment explored 4 categories of things. So how is oral health being assessed and monitored in the facilities? what types of hygiene supplies are available to perform daily oral care, what kinds of training and support exists for caregivers in the facilities, and where can improvements be made there. And then lastly, are there already opportunities or ways that the 4 M's within the age-friendly health system framework, are they already connected to oral health or could be easily connected? And the findings of our needs assessment are shown here. Maybe not super surprising. I think us who've worked in oral health for a long time are used to being kind of the redheaded stepchild, that oral health is rarely a priority, and the same is true in long-term care facilities. There's just a lot of priorities that are competing, and oral health doesn't make it to the top. The second one, called resident resistance, I might, argue against calling it that. I think residents are not accustomed to having a lot of interventions done in their mouth, and it's, a sensitive head and neck region area anyway, but it's kind of a snowball effect. If you don't perform those daily cares, things get worse, the gums get more sensitive, it gets more uncomfortable. So there is some perceived resistance, but I would say it's more of a lack of tolerance and being accustomed to having that be normalized and desensitized to. The third is limited access to dental homes, particularly in these rural long-term care facilities, where there may or may not even be a dentist in that town or community. And if there is, there's so many logistical barriers around, which is number 5 there, around transportation, care coordination, payment, and then, no mobile or on-site dental services, which would eliminate some of those logistical barriers. So they're all kind of interconnected. Our recommendations from the needs assessment included standardizing assessment of oral health needs. And, there is the minimum data set, which has a section L that's devoted to oral health, but there isn't always an oral health professional that is doing that assessment. There's a convenient could not assess checkbox that, for example, a nursing staff could check off if they're unable to make that assessment because of lack of training or knowledge, or cooperation of a patient to have them perform that assessment. Workforce, importance of training caregivers and linking them to oral health professionals to do that, really maximizing community collaborative dental hygiene and dental therapy, which is a really exciting part of the workforce we have here in Minnesota. That may make it less, the barrier of entry for a dentist being integrated into a long-term care facility versus some of those other oral health team members. Preventive services, emphasizing that, for comfort care, for stabilizing existing disease, and for preventing future disease is a little bit easier to launch rather than getting from 0 to comprehensive care. And then lastly, really being creative with payment models to potentially incentivize dental providers to establish relationships with the nursing homes through like a dental director contract, or hopefully maybe someday some telehealth or in-facility care models like Apple Tree offers. Okay, the next phase is train the trainers. So we provided some in-service education. And here you see the description of who was trained. 57 caregivers responded to the survey. And I was not the one who personally did this training. Nicole Farian, our Director of Clinical Innovations, had participated directly. So there may have been more folks trained, but 57 individuals completed the survey. And as you can see, many of them are nursing staff, CNAs, and over 2/3 did not have prior training in oral health topics. So this was a great opportunity for them, and largely women. You're not going to be able to see the specifics on the knowledge pieces of the assessment, but pre and post, if you look at the blue and the orange bars, are post assessment, their knowledge improved. The biggest jump was in understanding that you shouldn't brush dentures with toothpaste. That's always kind of a trick question, right? We can people don't realize that it scratches the acrylic and introduces some issues. But in general, some questions more than others, knowledge was enhanced after those trainings. And then the other piece we assessed was confidence. So knowledge is important, but not sufficient to maybe motivate some change. And so the assessment of confidence, there was, modest increase as well in the positive direction. And I would say those both are very nice. Knowledge and confidence being increased through these end services, but there's, a ton of other barriers that we can continue to work with some of these facilities to create capacity and make oral health a priority. The last component of our pilot was outreach to do those screenings and coordinate care for any needs that were identified. And we had opportunity to integrate 3 pieces of technology, teledentistry platform, intraoral imaging to really get a clear sense of what was going on, communicate to caregivers, some patient education, direct support, professional education, nursing staff education. And then we had the opportunity to integrate this caries detection optical aid to, again, for patient education and also communication with caregivers. It was a very small pilot. This was kind of the time of a lot of disruption at the state and federal level. So there was some delays and we weren't able to expand. We were hoping to get a much larger pilot, but here it is. Here's what we were able to accomplish and learn. 9 residents reached in a very rural long-term care facility, average age of 81.1 years. There were 2 residents that had some dental caries identified, and we were able to treat right then and there with SDF, with an advanced dental therapist and a registered dental hygienist on site. And most of the patients served were women. And you can see in the images, it's a very scaled down, kind of in the bag type outreach, very focused on prevention. Oh yes, SDF is silver diamine fluoride. It's a medication, a liquid medication that can get applied to teeth to arrest dental caries, harden the tooth structure, hopefully prevent the disease from progressing. Thank you. So what we learned from our outreach pilot is that if this intraoral imaging tool was helpful, it's a scope that gets strapped onto your phone. It was helpful as a patient education tool, as a clinical record tool, communicating with guardians, coordinating care potentially with a dentist if we were able to refer them. But we did find that the scope, it was plastic and kind of rigid, and a lot of the residents were, frail in their tissues and very sensitive from lack of regular daily care, some, lack of comprehensive access to comprehensive dental services. So it was just really difficult for some of them to wrap their lips around that hard plastic scope and open their mouth wide for that 30-second scan. And we actually collaborated with that company of the scope to, they developed a more silicone flexible and smaller version of their scope to adapt it to more sensitive populations. So that was an exciting outcome. And the Blue Check, the optical aid product that we also incorporated, we found that with the dry mouth and sensitivity, kind of lack of tolerance for anything to do, anybody doing anything in the mouth, made that less successfully implementable. And the extent of decay, this optical aid is really good at detecting early stages of dental caries. And in this population, you don't need an aid to see that they've got decay along the root surface or, on the coronal surface. So not super useful in our experience with this population, but maybe after daily cares are being consistently offered, comprehensive dental services are more consistent and routine, the tissues are healthier, maybe we would have a bit of a different experience. But bottom line is both intraoral imaging seem to be important and telehealth enabled systems were important to expanding access to care to this population that didn't have an existing linkage to a regional dentist. And so trying to forward something if an image is included or more information, definitely more helpful, and being able to offer some preventive and therapeutic services that were minimally invasive on site. So outcomes of all 3 components of the pilot, the train the trainer, the needs assessment, and the outreach to a rural nursing home, shows that we really do need to develop and share best practices for models of care delivery for older adults in long-term care facilities. that include training of the staff, educating residents and their families on the value and importance of access to oral health services. Teledentistry is a really great tool, as well as minimally invasive options for preventing and managing oral disease, and utilizing the full oral health team, as kind of we did. And also just, you know, identifying need, triaging, referring is one thing, but establishing a stable, long-term dental home connection to those nursing homes is really important and is a challenge in those rural communities where there just isn't a dentist that is nearby or able to connect and serve that population. That's all that we have. Happy to engage in discussion or answer questions. Yes.
Thank you so much. My question is, do you guys go back after 3 months or 6 months? What I found in my work is people are pretty excited or paying attention to the first time you saw them, but then as you mentioned, getting priority and then 6 months later, they're like, oh, we haven't talked to them time. You doing a follow up with them?
That's a really great point. And also, you know, a matter of 6 months, even 3 months, sometimes for this population, things can change rapidly. So, you know, oral health preferences and priorities, agreement to treatment plans can change rapidly. In this particular pilot, because of some of the state and federal suspension of funding and interruptions in care, and trying to, you know, when we kind of lost momentum and weren't able to re-engage the facilities and expand, you know, continue to come back and not only see additional residents, but see the residents we screened and examined initially. We weren't able to, unfortunately, but I agree that that's really important. And that is how our care delivery system generally functions, is that continuous comprehensive model.
Yeah, maybe I'll just elaborate on that a little bit. So this was a pilot to a non-apple tree site in a HRSA without an apple tree delivery system in the area, just to clarify the scope of this. For us to have a comprehensive program in a facility, you need to have enough residents there, you know, to have a regular schedule. So that's easier to do in urban areas where you have, you know, nursing homes with 100+ residents. We actually did a study with Steve years ago where we looked at what predicted utilization rates in long-term care facilities, and having enough residents there so that a team can go back and have a busy day. Going to 2 or 3 places in an urban area in a day, you can be busy if you're a hygienist because they're right nearby. But if you're rural, you know, maybe you can only go to 1 or 2 in a day. So that's where in this we're really thinking, well, how can we really optimize the nursing staff? How can we have a hygienist or a dental therapist do as much as they possibly can there, using telehealth connections to dentists that are remote but have the geriatric training and so on that can help them. So it's really, this is kind of getting at a question, how can you go to places that are so remote and the dentists aren't nearby and really leverage training and the rest of the medical and nursing team to help people get healthy and meet what matters to them, kind of thing. So,
okay, there was no clinic in that area at all.
no,
Dental was, legal was the only
right.
provider was the, and then their prevention was there. It was just great, so it's really like other than
Part of it too was the experiment with the scope. We've been working, for part of CareQuest has a group called Innovation Partners. I don't know if people are familiar with CareQuest. They're a huge national philanthropy in oral health, and they have a program where they partner up startup companies with folks doing dental public health type work. And so we worked with them actually for like 3 years now. We helped develop their first pediatric for preschoolers, a scope version of that. And in 30 seconds, you can get a super duper crisp, well-lit movie of the entire mouth. And it has AI bundled with it that creates a set of standard still images. So kind of like a full mouth set of photographs, high res. And they're building a whole suite of tools to detect periodontal problems and, you know, all kinds of things from the visual images. And then you can share them with the family. And in long-term care, the family's not there. You know, the people that are making the treatment decisions are rarely there. They're usually, you know, nearby or in another state or at work or something. So having a picture is worth 1,000 words. And being able to share that, whether it's a pediatric or an adult or a geriatric patient, is really helpful. So that was part of this pilot too, was figuring out how can we do that in more remote areas? And can we make a workflow that works for them? Sorry to.
No, I think there's one more question.
I have a question on that. All of us know that these long-term care facilities and staff and nursing assistants, they are overloaded with the amount of work they have to do, whether it's care or dispense medications. So when now we are adding that to although we're very important, now we are adding another task on their list of unlimited tasks. So what is their reaction and what kind of support do you have received from them, specifically with the facilities we're working with? Because this one was probably a pilot. So, you know,
Yes, that's a vexing problem that Steve and I, the rest of the geriatric world have been struggling with for our entire career. It's not only just the short-term question, like one-on-one, you've trained somebody, you're asking them to do a new thing, which doesn't matter what the new thing is, that's hard anyway, right? But the turnover is so high. The turnover is so high, and I know Steve has done intensive, and we've done intensive, you know, follow-up and this and that, but the turnover is so high that, you know, the learning drops off really quickly. So one of the things we've kind of concluded is having an oral health champion in each site that has the right equipment to deal with dentures, to safely get into somebody's mouth, maybe has Parkinson's and they can't open up. How do you get them to open it up? So there's a lot of technique in that. And I think one of our visions is to have a trained oral health person that works across the different units and is supervised by the nursing staff, but supported with a hygienist. And part of the key to making that work, as with all of this, is creating a financial model and a workflow. So, yeah. Yeah.
No, I would just point out that it's gotten tougher and longer. That's breaking of long-term care, and we are now making it.
I don't know, I have another meeting.
Great. And I would second Mike's notion here. To me, the only answer after all these years is having long-term care facilities required by regulations to have a hygienist or a therapist or a dental professional on staff a certain number of hours based on the number of beds they have, because trying to get staff to do it is not. They are required to have hair salons and all, and rehab.
Oh, yeah. Thank you. Oh, no. Absolutely.
I recognize just the
staff for an hour of information interview the director and step in.
No, I can look at something. I can see it right in front of my face.
The law is so broad, it's not just one that I. And then I know I did ask the director, like, you know, like all the hair brush shampoo. So toothbrush, it's the same one as my name. So they can either.
This is what I've been before.
It's
Oh, thank you so much. I know they have, oh, there, Dr. Slashcheva. Thank you very much, you guys. We really appreciate it. We didn't do a proper thank you. But I know Dr. Helgeson had a meeting, so we. Oh, thank you. Yeah, well,
The new tech person in town.
yes, the slide whisperer, what I'm going to call her. Our next presenter is Dr. Susan McKernan. She is an associate professor in the Department of Primary Dental Care, the Division of Dental Public Health at the University of Minnesota School of Dentistry.
Welcome.
Now I think it's working.
Looks great.
Yes. I have new learning today.
Yes. Thank you. Is the microphone on? Okay, now the microphone is on. I'll have to moderate my voice because I tend to talk very loudly anyways, especially when I get excited. So I am going to talk about some of our activities that we've been working on in partnership with MDH. This slide, I'm just showing an overview of some of the things we've done in the past, what's ongoing, and what we're planning for the future. Past things that have wrapped up include the Rural Dentistry Postgraduate Fellowship, our Rural Predoctoral Extramural Partnerships or Preceptorships. Ongoing right now is our Predoctoral Rural Dentistry Career Track, which is for dental students who are interested in working in rural communities, mostly in Minnesota, but we have a few students who are from the Dakotas and Montana as well. And then proposed with the most recent HRSA grant application is looking at some extramural rotations for our dental and dental therapy students, where they get to go out and work with mobile dentistry in some senior living facilities. For all of these educational activities, we have some key components. As Dr. Shuman and others have mentioned, we integrate the age-friendly health systems framework, including the 4 M's, and also include hands-on clinical experiences and learner-led projects where students and learners can customize, individualize their learning based on self-identified interests and passion, and as well as local needs. I'm going to focus on this most recent activity, the Rural Dentistry Postgraduate Fellowship. And that's what I'm going to really talk about here for the next few minutes. This is a 12-month program. It ran from June 2025 through June 24 through May of 2025. It's a pilot program. We had 4 individuals, including 3 dentists and 1 dental therapist, participate in this fellowship. These are all providers who currently work in rural communities in Minnesota, and the fellowship kicked off with their participation in Dr. Shuman's geriatric mini residency. And then from that, then we had 1 day of in-person learning and engagement at the School of Dentistry, which is just across the street, if you're not familiar with that. And then we had virtual learning sessions every other month that we had readings and then community-focused assignments between each session. And then every participant worked on their own mini capstone project that wrapped up with presentations at the dental school in April of last year. Everyone in the program also participated in hands-on specialty continuing education at the dental school. And so this included things like oral surgery or endodontics, because one of the issues that we hear from dentists who practice in rural communities is that they're the one-stop shop for their community, all of their community's dental needs. And so they often have to act as the specialist, right, for extractions, for root canals. And so that's one of the gaps that people often talk about for dentists and dental providers in rural areas. The fellowship included about 65 contact hours of learning, plus individual meetings, mostly with me, for their capstone planning. CE, the mini residency, everything was provided free of cost to participants, and this was supported by our grant from MDH. Participants also received a stipend for their participation. We met during regular work hours, and so it took a lot of planning to find a time every couple months when people could meet for 60 to 90 minutes. As well as me, other faculty instructors included Drs. Karen Quick and Carl Self. And the curriculum over the 1 year period emphasized care for the aging patient. It emphasized the 4Ms approach, right? So the age-friendly health systems framework in clinical practice. We also included some kind of community-based public health topics, such as oral health needs assessment, state oral health surveillance, local public health activities. So most of our participants were in private practice. We had some in FQHCs, but just worked on identifying community resources for public health support. Also talked about oral health policy and advocacy, and included some information about social determinants of health, how those influence overall health and oral health. So I think the highlight of the program was really the mini capstone project, which I don't know if I told you you had to do a mini capstone project, like I think most of us would feel a little bit like overwhelmed because it sounds like a big thing. So I know all of our participants came in feeling like this was going to be like a really kind of like stressful activity, but it really turned out to be, I think, the highlight of the program, because we asked them to develop a project that addressed the goal of increasing age-friendly health systems based oral health care in their community or their clinic. And we started with them reflecting, doing some self-reflection on their learning from the geriatric mini residency and applying concepts to their clinics, to their communities. And they really, had such thoughtful insights, and they found such meaningful, kind of relevant information and very different needs from the communities that they are coming from. And based on the gaps that they identified, we, over the 1 year period, developed a project that was relevant and meaningful for each of their locations. We had a formal process for this, and the emphasis through all of this is on utility of the final product, because you're all very busy and no one wants to waste their time. And ideally, this is something that people find value in. These are, so 4 participants. These are our 4 capstone projects that got presented at the end of the fellowship. So very different products. One of them, so the first one here, one participant developed an informational sheet for patients. The target audience was caregivers of aging patients and provided instructions on at-home dental care for seniors. So incorporated resources from the mini residency. And then throughout all of these activities, we emphasized, identifying evidence-based materials and practices, and kind of that process of how do you search for this information. Another capstone project looked at workflow and creating a workflow process within their tribal clinic that addressed nutritional counseling and referral options for edentulous patients. Because this participant, one of the issues that they struggled with was when they did full mouth extractions to prepare a patient for dentures, they found that there, was often a long lag time before dentures could be made. And they had patients that were struggling with nutrition. And most of the resources that were available were not culturally relevant for Native American patients. And so our fellow worked with a nutritionist in IHS, worked with people on the medical side of the clinic, and developed a process to catch patients before they kind of slipped through the cracks and started to develop like nutritional issues so that they could support the patient throughout this process. Third project was developing a grant application. I don't know if it was successfully submitted, but to secure funding for a mobile patient lift, not a patient life, it's a separate issue and kind of beyond the scope of the project, but a patient lift, because one of the issues that he struggled with in his clinic was they did not have a patient lift, and very frequently were running into limitations with transferring patients for care. So worked on, putting together a grant application for that. And then the final capstone project was modifying a caries risk assessment tool for aging patients to use aging patients and caregivers in their clinic to talk about protective factors, risk factors, and recommended interventions. And this, again, customizing available resources for their local patient population. Like what was actually available for their patients to go buy from Walgreens, right? Like not, what's the ideal kind of toothbrush, but what is available locally. And then also thinking about what did the clinic need to provide as well. And this, one of the things I always love to talk about is that these projects all address like local solutions for local problems, customized, culturally appropriate recommendations and care. So was really just a really rewarding experience to see our participants develop these things and to see them get excited about it. I'll wrap up with some of the issues. We've talked about sustainability and long-term, what do we see for the state? The fellowship itself was very resource intensive, took a lot of time, a lot of staff and faculty effort. It was a small cohort that required, mentored learning and engagement. We provided a stipend. Half was provided at the beginning of the program, half was provided at the end. And I do think that was a strong motivator for engaged participation. And I say that as someone who, if you wanted me to complete a 1-year fellowship and like meet every couple months and turn things in and like, engage, you would have to pay me, right, to buy my time. Because otherwise what happens, and I'm sure we all do this, is, you sign up for a webinar next Wednesday, but then next Wednesday comes around and, my car needs an oil change or someone else needs to meet and they're going out of town. So when we have a lot of competing demands, I think the money is an important part of this, despite all of our best intentions. In a next iteration, if we are able to continue this, we need to modify it to be more scalable, less resource intensive. I don't think it can be totally just an online self-paced curriculum, because the peer group interactions for networking and just engaged conversations were really critical to people having good ideas, people bouncing ideas off of each other and learning from each other. I think we could move to some asynchronous components, but really still would need not in person, but face-to-face interactions. And then amongst all of this, there is the uncertainty about current political climate, federal, state, and then at the dental school, we currently have an interim dean who has been in place for about 1 month. Just got an email this morning. They're going to start a job search or start a search for the next dean in the next month. So, a lot of what we do, especially around rural health and geriatric dentistry, depends on priorities of our new dean and priorities of the university system. Thank you so much for your attention. And if anyone has any questions, we're happy to talk more.
This is kind of a question, but is the long-term care like explain this in short-term care, would that be available to students who are currently?
Yes. That's the hope.
That apple tree, we found it interesting that, grant, who's gonna fund a quarter lift, right, or a student lift, and we kind of, find the fact that OSHA, it's a work saving issue, and they were really lift to avoid injury.
Yes, and it's through the state, right? And that's who we were targeting with this as well. Yeah. So there is state funding mechanisms available if you need a patient lift. Thank you. I'm not gonna touch anything.
Yeah.
because I don't-
Thank you so much. That's my theory. I think we need OSHA for our little, right? That little step stool. It's a little scary.
I can just.
Thank you so much for that. You know what I really love, there's a lot I love about today, but one of the things that's really coming up for me is because this is grant funded and people are trying new things and people can say, well, this didn't work so well. And sometimes it's out of our control, like what you guys dealt with at Apple Tree. But that's why we do pilots. That's why we try new things and we learn. We go, oh, next time we'll do X, Y, Z. But I love hearing that from all of you. I think that's super helpful. Wonderful. So our next presentation is community health workers and older adults. And our presenters are Tuesday Glover, program director, certified community health worker, DHS certified caregiver consultant, culturally responsive caregiver and support and dementia services. Wow, that's a great one. And Monisha Washington, community health worker, and she's the CEO of Link. So welcome, you guys. Come on in.
It was the other side, so.
Again, thank you for having us. Again, I'm Tuesday and I work with Volunteers of America. We're a culturally responsive caregiver support and dementia services team. And I just want to give you a little data. Our program, we serve over 2,500 people per quarter. So we are busy. Volunteers of America has many programs. So they're helping with housing. They help with incarceration and in the high rise. I'm trying to remember this off the top of my head. And then caregiver support services. And we also have a school, which is good. But we're here today to talk about community health workers.
Hello, and I'm Monisha Washington, and a community health worker. Fun fact, Prasida was my actual instructor when I was in community health worker school. So that's how I connected with her. So I was trained by the best, right? My organization is The Link. We are a consulting agency consulting with multiple organizations. We say we are the link between your mission and community. We use community health workers to actually go out and do outreach and engagement in the community. And I'm happy to be a part of partnership because this is not done. As you see, we always do things in partnership and not alone. And so I'm a part of the beautiful partnership that that Minnesota Department of Health put together.
So as we work in the community and do outreach, we are really collaborating with community organizations. We cannot do this alone. We are meeting people right where they're at, Minneapolis public housing, right in their high rises. We work with MDH, of course, and I thank you. Open Cities, we collaborated with them, and Monisha will talk about that a little later, as we did our community health worker training. We also collaborate with North Point, they have community health workers. And the YMCA North.
So I'll just speak about the role. A lot of people are familiar now with community health workers, but we really are the front line. We are the ones that are out in community. We look like the community. We assess with the language barriers that are out there. We may be at your church. We may be at your beauty salon with you. We're there, and we've made these trusted relationships to bridge the gaps within community. And also thinking about navigation of care. We heard them talking about like Lyft and what to do when you get into care. Well, how do they know how to navigate that beforehand? Those are the community health workers that bridge that gap. And also just thinking about the social determinants of health. I say, well, we eat, sleep, play, and pray. That all is a part of a CHW role is really to, I'll keep clicking this on the wrong side, sorry. Role. And so with this project, we went into the train the trainer model. We've done this project, train the trainer model before. And so I was happy to do it again, where we were actually trained by MDH. I was trained as the lead CHW and then went out and trained other CHWs. So with the partner organizations, Open City was at the table with their CHWs. The other partners, Volunteers of America, also have CHWs as well. And so we were able to train those CHWs on oral health. Prasida can also tell you that in our training as CHWs, it's a quick turnaround of our training and our certification. And so we can't really dive deeply into oral health. And so that's why it was important to do the train the trainer model on oral health so that that is spread within community. And they actually get more education on what that looks like. This is one of the stories that I brought up when I was talking to them, because they needed to know the seriousness of oral health. What that it can actually unalive someone. Someone cannot be here. That's how important it is. And we as, clinicians, people who are working in oral health may know that. But if you're not and you're working in community, you may not know how the severity of it. So I brought up that story. And then also, how do we connect the mouth to the body? Because a lot of times it's separated. And I have them look at this right here as we're talking about all of that and think about, when you think about dementia and oral health, how close is your mouth from your brain? Just think about that. That abscess went to where? And how did that young man pass away? It's how close to your brain. And people don't think about that. They separate the mouth from the body, as we all know, right? So it was important to connect the two, dementia and oral health. And Tuesday is actually an oral health provider, dental dementia provider. So she is very well versed in that area.
And when we talk about dementia, people just think about the brain. But when we go into the community, we educate about the risk factors for dementia. So we're talking about the whole body. We're talking about everything associated with the brain. Just think about it like this. If your heart is connected to your brain, if your heart is not pumping correctly, you may have some issues with your brain. So, and we talk about oral health. We talk about mental health. The two things we really focused on in July and August, mental health and oral health, as it associates with dementia.
And like she said, when we think about the full body and the risk factors, think about what those risk factors do across the board with chronic disease. It's not just oral health, right? Those are the things that we're facing across the board. They're the same risk factors across the board. And so why not integrate oral health when talking about all of those things and the social determinants of health and them going out into community and educating? And there, as CHWs are trained, we know that more people in community is trained. And then they can then educate and implement that within the community, and they can help people manage their health and risk factors when it comes to what? Oral health. And so what is the scope really of a CHW when it comes to oral health? Assess, advise, assist, arrange, and address and adhere. So assessing the problem with the teeth and the gums, really looking at having those conversations, assessing it, doing the intake form, and we'll go a little bit more deeply into that. Then once you do that, we're not telling them what to do. We're not just saying you have to go and now you got to brush your teeth 5 times a day and make sure you floss. And, we're not really telling them what to do. We're really asking them what's important to them and how can they implement oral health better in their overall health and well-being. And then we assist them with navigating that system, talking to them about, hey, if you have mobility issues, let's actually call the doctor's office ahead of time, dental office ahead of time. Let them know about those issues so they'll prepared when you go in. Because a lot of times, what are we doing? We're just setting up the appointment. We're not going into the details of what they actually need when they get their childcare, all the other things that come with it, the barriers, and addressing those with them, and then finding out how to really navigate them to a dental home. Well, that's a whole nother conversation. But and with that, when we went into and trained the CHWs, we actually came up with an integrated form for outreach that created. So they typically did an intake form, when they talk to a patient, but now it's an integrated form that focuses on oral health. So I was trained, and when they came to me and trained me at MPH, they had a lovely training, but it was all evidence-based. And I was like, you know what? I was a dental assistant before I became a community health worker, and it's kind of over my head with all this evidence-based, and sometimes it's all the acronyms and things, and I'm like, what does that mean again? Can you go back to that? What was that acronym? And so I was like, this doesn't translate well to community. And it's definitely not going to translate well to the community health workers that come from this community who have to implement this. So guess what? We scratched that plan, made a new one, and came out with a better tool. And with that, we were able to not only train the CHWs on the tool, but we went to the YMCA and we had about 22 people who were in person with us. And we actually let the community look at the form, and they were able to say, hey, because I believe in co-design with community. So they looked at the form before we actually implemented it into the high rise and say, oh, this is a great form. Yep, this is something that looks like we can roll it out. And that wouldn't have been able to happen with that evidence-based one. Sorry, MDH, but it wouldn't have.
Clarification, so that form has all the 4 ends.
Yeah, yes. And it was a new concept for me the 4 M's and the different, I was like, hold on, mental mobility, no, mental wasn't in there. So I was struggling a little bit with keeping up with that. So, but the form actually still has the 4 M's in it. With the 4 M's, we're able to touch every milestone with them to make sure that they're actually able to navigate their care when they go into community, that they can talk about what hurts, what doesn't, and it's a tool for motivational interviewing. So we're not just checking the box. We're actually having conversations. It has little tips and tools for the CHWs to be like, okay, let me dig deeper on this. You said you couldn't eat last night. Well, why couldn't you eat last night? But what was the real issue? Getting to the real root cause of what it is versus the surface level conversations we can have on firms. I know the community is surveyed out. I know we got a lot of surveys and evidence-based and stuff, but we surveyed out. So it's real conversational versus survey.
So in 2016, we had an opportunity to buy this mobile clinic. And we are definitely meeting the people where they're at, in the communities, at the community events, Selby Jazz Festival, Rondo Days, churches, high rises. If you guys need us to come to you, you let us know. And so if you know of anyone that's a hygienist and wants to come on the mobile clinic, please let us know, because we bring it right to the community. So we were at the YMCA, like I say, the high rises, any brain health event, health fair, we're there. So please let us know if that's something you want to collaborate with and get the services right to the community. It is so needed.
And Tuesday can also tell you more of the services that they provide on the mobile clinic. Now, this is the first mobile memory clinic in the nation. So it's very innovative to have a mobile memory clinic. And then they actually they partner with so many people to bring so many services on that mobile clinic. So we're not just doing oral health, but you get them and meet them where they're at by doing something that really pertains to their health, whether that is.
So, sorry. So after assessing our community, the needs are health screens. So we go and do memory screens, cholesterol, A1C, glucose, lots of health education. We're doing the PHQ-9, so we're doing a depression assessment. And our community health workers really are connecting people who need more workup. They're connecting them to local clinics because a lot of our people don't have like a home-based clinic, and we want to stop using the emergency room as a main access for care. That's one of our missions. And we have a nurse on deck. And then we have 2 social workers. So I'm really excited about having this mobile clinic.
So what does all of that sound like to me? Wraparound care and services. A lot of the time we just navigate them, give them a call, get them in, but we're not doing the wraparound piece of follow-up care, the pieces of navigating everything. If you have a social worker, a nurse, a CHW, all of this in one, it helps do the full follow-up. And that's what a CHW really can do to help navigate oral health. And one thing that I was pushing is like, yes, we get them in for their appointment, but then do that 6 months out because we know that it's hard to get in, right? So we need to be navigating well ahead of time to get them into their appointments. But why is it important? Do you think, why would it be important to bring oral health? And I'm gonna ask this question to you all. Why would it be important to bring oral health to a mobile clinic that provides all of those services? What are you seeing the connection between A1C, blood pressure, and all those things in oral health? I'm gonna wake y'all up a little bit. This is a call of response. Why do you think it's so relevant to bring that alongside those pieces? Say that a little louder. Yes, the linkages. What else? A1C. When you think about A1C, what are you thinking about? Blood sugar. What does blood sugar do with teeth? Oral health. What are we thinking about when it comes to blood pressure? Aren't they doing blood pressures now when they going into to the dental office? So do you see all of how that all is connected and how we can wrap that around and educate while we're in community about all the things that they're gonna, that oral health linkage, like you would say, to their overall health before they even get there. And then when they get there, they're gonna ask questions. And one of the things I stress to them is tell your provider about your oral, everything that's happening in your overall care, because guess what? We know that there's a divide, even in the providers. So making sure that they know what medications you're on and things that and so we're talking about all of that, the things that could cause dry mouth, all of the things, we're talking about all of that before they even get there. So we just want to make sure that when we're doing oral health, we're removing those barriers and really bringing it to overall health and well-being. But we know that the barriers, there's multiple barriers that we, even as CHWs, have to face, not just the community as well.
Yeah, I kind of got stuck when thinking about the barriers. So I did reach out and get some professional advice, and just thinking about CHWs, and I have a team of CHWs. We can't even reimburse for oral health education. And we're working on a tight budget. So if we can get that in place, that would be amazing. The CHW curriculum lacks oral health, which makes it difficult to introduce advanced older adult and health information during training. So that's why it's so important that we had our training for our CHWs. That was so nice. CHWs are from the community they serve. So we usually look like the community we serve. 2016, we had Hmong community health workers, we had East African community health workers, and then we had the African American community health workers. So we definitely looked like the community that we were serving as we went out into the community. And I think that's so important because they spoke like the community, they're more comfortable speaking with them. I just think that's amazing. Represent and look like the community that you are serving.
Yeah, and then one of the things when we think about barriers, it's not just our barriers, but community barriers and access. And we know that there's a shortage. We know that there's a lot of barriers there. And so that's one of our main roles. And we're so thankful for this project because the more CHWs that are trained, the more that we can help navigate the system around oral health for the CHWs. We can integrate CHWs within dental practices. We can be that bridge between the providers of, primary care and also oral health and really bridge that gap. And that's what we're trying to do with this project. We've provided resources to our CHWs. The list of resources are here, but we want to add more resources to this list. So if you have any, you can feel free to send those resources over. We are appreciative of your time. BOA does have a helpline, and so we love for you to call if they need caregiver services, if they need navigation or anything. Please give them our that as a resource for navigation with our community health workers. Any questions?
You looked in the Orvik integrated forms, right? Using that form for staff.
What was that? I'm sorry.
So you'll be continuing.
Oh, yes. And so yes, we did the YMCA where we did that and they looked at the forms, and now we will be going into the high rises and implementing those. We are still using those forms to implement that, and then we'll come back with some more data by the next meeting. Yeah. Thank you. It's here, it's here. As this folder is, okay, I found it. I only have one slide, so I know everybody's tired. So I'm presenting on behalf of health partners who helped us literally close the gap, integrating medical, dental, electronic health records with the 4M framework for age-friendly care. So it goes back, so at the time of writing the HRSA grant, when Dr. Shuman introduced me to age-friendly health system, we knew it existed in the hospitals as quality improvement measure. And there were guidelines and a lot of handout and resources for hospital systems, but very limited work was done in public health, and forget about oral health. So not just dentistry, we were trying to use this model in dental public health. So it was a big undertaking. So in the last 4 years, we've worked very intensively with Dr. Shuman to come up with what does these 4M look like in a dental clinic? In short, when can you call a dental clinic age-friendly, right? So we talked about 4Ms, what matters, mobility, medication, mentation, but they have not been really used in dentistry in a more structured way. Like I might ask my patients about medication, I might ask about some cognitive impairment, mentation, but I may not talk about their moods like Dr. Shuman was talking about, right? The anxiety or depression. I may not talk about what matters to them, or how if they would need some patient transport, and forget about those mobility issues or fall in the dental clinic. So what we did was we wanted to first use the guidelines and collect some data to see if we can come up with minimal data set. For example, what are the variables that we could collect as dental providers, or we could ask medical providers to share with us so that we have information about mobility. What can we look for when we talk about mentation? What are the things we want to look for when it comes to what matters? And what is the list of medication that we really think are high risk for our older adults? So the purpose of this electronic health record medical dental integration was to see the feasibility of interoperability between medical system and dental system, which are these two EHRs, right? And I think it was a huge undertaking for us to even think of electronic health record in the first place, because we know most of our grantees used open dental, but again, on the medical side, we kind of knew about Epic, but we didn't know about others.
So that's why we work with health partners, because they have an integrated system. Their medical and dental providers had access to the charts. So we worked with them and we analyzed over 5,000 patients' data. And the interesting part was generally we involve our epidemiologists and data scientists to do this work. But for the first time, we used their EHR specialist, which was very interesting, because we were trying to see if we can replicate this kind of electronic health record integration in other practices as well. So we used more like drop-down menus, or we ran the reports, and we tried to keep it to EHR versus what our providers would have to do, like chart reviews or go into patient information and dig into dig more information. So what we did was we came up with the variables. So for example, for what matters, even though from the long-term care facilities, we know like doing the hair, nails matter, but in electronic health system, we couldn't do that, right? So we had to rely on care plannings. So similarly for meditation, we had to rely on more mini-cog or other mood and depression or anxiety screening tools. And for medication, we had a list of high-risk medication that generally causes, like the dry mouth. So because we came up with these guidelines with Dr. Shuman, we wanted to see if we were able to even pull this information from EHR before we put it out as guidelines. And we were able to successfully integrate medical and dental electronic health records. And what we found was, sorry, give me a second. So structured age-friendly data were present across both the systems. So this is a possible, I'm just trying to read the fonts and I'll show you the slide. Sorry about that. So only 20% had advanced care planning documented. More than 60% were prescribed xerostomia-induced medication. More than 60%. Cognitive decline and depression were increasingly common with age. We did see an increase in anxiety, but it was sort of like borderline. So we couldn't say, oh, there is an increase in anxiety among this population, but we did see, both cognitive impairment increase with age. 12% reported multiple falls in the last year, which means they might fall in the dental practice as well. Oral health needs remained significant. 68% had periodontitis, with higher prevalence among patients with diabetes and tobacco use. So all our findings were consistent with what we were reading in the literature, but we were at least able to come up with some sort of data to validate that the guidelines that Dr. Shuman had developed in the last 4 years, one, were feasible for us to use across medical and dental electronic health records. Second, there were like enough evidence that we generated using, like a sample of 5,000 patients that aligned with literature. So we were successful in our, so the aim was to really see the feasibility of integrating medical and dental electronic health record, and it is possible. And we were able to really come up with minimal data set, and now we are in process of creating a practice toolkit that would be shared with dental clinics, and then that would be the measure for calling a dental clinic age-friendly. So Dr. Shuman, do you want to add anything to this project with the EHR work we did?
No, except that, what we have found on our own, especially with the commercial electronic record systems like EagleSoft and stuff, is actually, they have a fair amount of customizability, and we actually do have, elements of, for instance, in medical history that could be added easily, and we used to do that with our previous clinic at Walker Methodist on EagleSoft. Of course, things like patient mobility assessment, communication about decision making. If it's the patient making decisions, if there's someone who helps them, those types of things, as well as kind of being able to flag high-risk medications for overdose. So these are things we kind of know how to do. It's just that, again, sort of tackling this in the larger electronic record systems, and then of course the fact that everybody's on different systems, correct, makes it hard. We're kind of optimistic. I know school will eventually get onto Epic, so we can start to do these things.
Yes, and I presented this poster at a medical conference, and I met with orthopedic surgeons, nephrologists, and they had such wonderful ideas and very different perspective to look at this poster. And I was trying to talk about numbers, and they were like, I think they started where I ended. They were like, okay, so you are part of a bigger health system helping us mitigate those mobility and morbidity issues. So you could be the first one to identify the mobility issue, because it might take 3 months, 4 months for someone to get into an orthopedic, like office. And a nephrologist was like, I would have never known about a lot of things that could be flagged in advance, because I'm not going to ask about mobility as a nephrologist when a patient comes for a dialysis. So I think for the first time, I felt like, okay, I could feel like mouth being put back in the body. And where we ended in terms of, being in the weeds, granular level, oh, this is possible, these are the data. I think physicians see it in a very different way, that we are helping patients bring into the pipeline, because we could be the point of entry, right, for them. So this project not just had the interoperability or feasibility of electronic health record work, which is still like emerging in medical and dental, integration space, but it also was an opportunity for us to have a list of primary care provider, because again, this came up in that medical conference that everybody has different systems. So one of the recommendations that I received was, why don't you maintain a list of primary care providers in your state? And then, they could just be, it's like a directory that our coalition could maintain, and we could just, like have a system to just email few things to them and with the consent of the patient. But again, the disclosure is that health partners, like leadership, Dr. Teri, Dr. Hindal, are very progressive, and they really want to do this. So again, depending on the leadership and, their vision, quality improvement, and a lot of other logistics within our system, medical dental integration, because if you remember, we've done a similar bidirectional referral model within FQSCs or facilities where medical and dental clinics were co-located. Trust me, the leaders talked only during our advisory committee meetings, and Nancy, you remember that. So just because clinics are co-located doesn't mean they are communicating. So just because 2 electronic health records are present and they are integrated, we are not taking advantage of those systems. And it really requires awareness and these kind of evidence-based framework for dental folks to be able to take it and then, be able to advocate for those things. And they need to see the impact of such medical dental integration. And I'm very thankful for Dr. Shuman that we now have the guidelines, and we will soon have a nice sort of like schematic or, like infographic sort of handout that can be shared with clinics. And they can use that as a checklist to call themselves age-friendly dental clinic, which was the whole idea of this 4 years of HRSA grant. So thank you, Dr. Shuman, for mentoring me in the first place and teaching me geriatrics. Like, I don't know how many years it has been.
The challenge, of course, is getting it out there.
Yes.
And getting practices to see the value in doing this. And so I mean, I do have to tell you that one of my big concerns, of course, is about funding. And the fact that it's hard to ask people to do things that they're not, they feel like they're reimbursed for.
Yes.
Willie Sutton, bank robber money, why do you rob banks? But that's where the money is. And I think then, my concern is that oral health care, moves in that direction too. And unfortunately, and by the way, it's not just oral health care, it's geriatric medicine, it's other areas too, where they're struggling to maintain them. Hennepin County Medical Center, good example. My wife was a long-time geriatrician hospice palliative care doc there, retired a couple of years ago, but one of the first programs that got cut into the budget cutting activities was their geriatric medicine extended care program, because it wasn't bringing enough money. And so that's one of my big fears is, money in healthcare try to mix. They don't have to mix.
Yep.
And right now, my fear is that the incentives, and as I watch with our program, and our special health needs clinic is tightly tied to the University of Minnesota Medical Center. We provide their on call for them. We also do medical clearances, dental clearances for their patients and things like that. Take care of their head and neck cancer folks. We have a hard time competing. you know, we need an operating room. Do you want to give it to dental? Or do you want to give it to the heart transplant team? You know, or somebody placement. So I think somehow in the policy realm, start addressing that finance issue, because I worry that we can have all sorts of great tools and information out there, but unless there is reasonable reimbursement for the service, I worry that dental professionals will be reluctant.
Anne is listening from MMP.
Yeah, I think that's the reality. I think this comes down to things like, you know, we ask dental professionals to be more involved in primary care, screening, and, you know, I think about when I went to dental school, nobody really cared whether we took a blood pressure or checked the person's blood sugar or asked about those things. And now those are considered important parts of dental practice because of our knowledge of how they
Right.
And so now when we're sort of asking people to try to apply the 4Ms framework and think about mobility issues for that patient, same cognitive issues, you know, or medications that they're taking that might be a concern. Again, these things take time, and if dental professionals are feeling under the gun financially, you know, I worry about how that's going to happen.
Yeah, but I know Dr. Crespo is also teaching our medical students a lot of dental screening and other things. I've been in one of her sessions as a resource person, so I know like we need more champions, right, on the medical side to be able to advocate for these bi-directional collaboration. So, yep. Nancy, do you want to discuss? Are there other questions or? Otherwise, we have like
Bilkis, right? Okay. If it's okay, Bilkis, if you could raise your hand. Bilkis Khan is doing the evaluation on this grant. So if you have questions, you could reach out to Bilkis and say hi to her today and get your contact information because we're at the end of our day.
Yep. Bilkis, anything you want to say just quickly or?
Just, I'll just stand up.
Yeah.
Today, I'm very impressed with the amount of work people have done for this in the past 4 years, and I'm very impressed. I was taking notes for antiquity and trying to capture things because these are very helpful for evaluation, because we promised HRSA that we will show some impact of all the courses that done over 4 years with partners, not just MBAs have done it. So it falls apart to the partners who were able to do it. So I feel like that anything and everything which you can offer us, which depends to HRSA that what we can do, who partners, I think this will be very valuable, and especially for future funding. We know that, as Dr. Shuman and again saying, because we have a lot of people see that funding is very important. Until and unless we show that something is sustainable, something is impactful, people are not going to fund. So in that way, whatever you guys have, I would really appreciate if you can share with us, with the Department of Health, and we can produce some valuable resources for people out there to see that what Minnesota has produced in over 4 years in the health of the country.
Because you'll be doing a lot of dissemination to right with coalition.
This was a good dissemination platform for financing for helping us come together. But then this can be disseminated at a larger scale. So it's something which we all have worked together to, this is what we were presenting to our own folks basically.
Yeah.
But then how to take it to the next level is something we would try to do even better. Thank you.
And Bilkis will be reaching out with requests for data and other things, right? Because yes. Okay.
Thank you. I just want to say thanks to everybody. Thank you for being here. Thanks to everyone who's done great work. And we look forward to seeing you again. And thanks for everything you do for oral health. And thank you, Prasida.